and welcome to the oral paper presentation under students category. SASH conferences have always been an ideal forum for communicating your research and your creative ideas to the experts in hospital and healthcare industry. This year too, we had an overwhelming response with more than 45 abstracts received this year, and our judges had a tough time in shortlisting 5 papers for today's final presentation. Let me inform once again to our presenters that they'll be having 7 minutes for the paper presentation, which will be followed by 2 minutes of question and answers by our judges. May I request Dr. Deepu Tree S., Head of the Department of Infection Control, and Dr. Sunil S., Professor and Head of the Department, Pediatric Nursing, to be our judges and be on the dais. So please. Our first presenter is Dr. Nikhil Boma from Nizam's Institute of Medical Sciences.
Good morning, everyone. Good afternoon, everyone.
Dr. Nikhil Boma, your time starts now.
Good afternoon, everyone. Today, my presentation is regarding cost analysis of COBAS 8800 SARS-CoV-2 assay in a tertiary care teaching hospital. I would like to share my screen.
Yes, please go ahead.
This is cost analysis of COBAS 8800 SARS-CoV-2 assay in a tertiary care teaching hospital. Basically, the first SARS-CoV-2 positive case was reported in the state of Kerala on January 30th, 2020. And according to the press release by ICMR, on May 8th, a total of 14 lakhs were suspected samples were tested in NIV, Pune. Among them, 56,000 were tested positive. Currently in India, we have 1,03,859 active cases which have been reported. And the Ministry of Health and Family Welfare of India has raised awareness about the recent outbreak and has taken necessary actions to control the spread of COVID-19. And basically this COBAS system is used for detection of SARS-CoV-2 RNA in individual or pooled nasopharyngeal sample, which are collected in 0.9% physiological saline. And the positive results from the respiratory specimens of the patients which are who are infected with this are diagnosed, and the negative results are again they are combined with the clinical observations and the patient history. This presentation is mainly focused on the break-even analysis, which is also called as a cost volume profit analysis technique, which is very essential for establishing a diagnostic facility in teaching hospital like Nizam's Institute of Medical Sciences. The main aim is to analyze the COBAS 8800 SARS-CoV-2 assay. Main objective is to study the physical facilities, workflow, and to evaluate the break-even analysis. And basically, this is a biphasic study, which is both prospective and retrospective study. This study is done for a period of 3 months, and that is from July 2021 to September 2021. And I have collected the data from the about the salaries of the staff from the HRD department, Human Resource Department, and also the expenditure that is incurred in the establishing the unit from planning section, and also all the maintenance costs and electrical engineering and civil from electrical engineering and civil departments. And regarding the physical facilities, an direct observational study was conducted. And basically, this equipment was installed in 7th floor of Millennium Block at NIMS on 5th September 2020, but it was functional from April 2021. The built-up area is around 52.5 square meters. and it is provided with a 7.5 ton on refrigeration ductable AC, and the total load on the Cobas unit comes out to be 54 ton on refrigeration. And and the equipment is provided with an uninterrupted power supply of 120 kilovolts UPS located in the UPS room, which is adjacent to the Cobas unit. Coming to the staffing pattern of Cobas unit, we have one professor, one associate, four resident doctors, one nurse, and five technicians. Record assistants comes around four people, and class 4 employees included are three. And I have calculated the total number of tests that have been carried out in the month of July, which comes out to be 7,000, and in the followed by August, which comes out to be 6,943, and in September it was around 5,724, which comes up to a total of 20,000 tests, 20,532 tests in a period of 3 months. The average tests calculated per day were 228. And this is the total cost of the equipment of Cobas 8,800 SARS-CoV-2, and total cost of the equipment comes out to be 2 crores 59 lakhs 1,103. Coming to the cost centers of the Cobas unit, whereas the salaries of the staff are calculated as a direct cost, which is of fixed type, and material equipment also comes under the direct cost. Building, air conditioning and electricity, laundry, linen and water, everything comes under the indirect cost. The total manpower cost, which was calculated for the study period of 3 months, was found out to be 52 lakhs 18,319. And the other consumable, the material costs, which of the Cobas unit, the total price of the consumables which are used in the procedure, assay, comes out to be total comes out to be 10 lakhs 49,748. Here comes the total cost of the equipment cost, where the equipment was purchased for the sum of 2 crores 59 lakhs 1,130 in the year of 2020. And it has a warranty period of 3 years, and taking the life of the equipment as 10 years, the depreciation amount is calculated by using sum of years method of depreciation, which comes out to be rupees 12 lakhs 95,055. The construction cost was calculated with the CPWD findings is found out to be 104, and when this for one building cost per 1 square meter is calculated, the total cost index came out to be 37,435, and for an area, this is for 1 square meter, and for an area of 52.5 square meters, the total construction cost is found out to be 19,66,912 rupees. Depreciation cost was calculated for 3 months, that is 49,172. The maintenance, coming to the maintenance cost, as per the CPWD manual, that is Central Public Works Department manual, the cost of maintenance per square meter is found out to be 5,104, and the total maintenance cost for the 3 months is found out to be 66,990. And coming to the total building cost for a period of 3 months, it comes up to be 75,455 for 3 months. Coming to the
Nikhila, your time is up, so we'll move on to the judges for question and answers.
Okay.
So basically, the Cobas system, just the system itself is costing almost around 3 crore. With just basic RT-PCR, we can get it in 10 lakh rupees, and per day test you are doing is like 228. So with the basic RT-PCR system, you can do almost a similar amount of test. So when a cheaper option is available, so what was the thought process behind going for an expensive system?
So because the patients who are getting infected and those who are getting admitted because of this COVID-19 has been increased, and the staff in our hospital are also at very extent they were getting infected with this infections. So we thought of installing a equipment which can I mean so that we can diagnose it. Samples which are infected samples at a large number. So we have thought of installing this cobas in our institute, sir, because this system has a load of around 3,900 samples at a time, sir, and it will take a walkaway time of within 4 hours only. We will be getting the results of all those 3,000 samples. Since we have a huge infectious load and a huge patient load, we had decided to install this in our institute, sir.
Okay. Per day, how many samples you are doing?
Per day, around 228 tests we are testing, sir, in this sample.
So you can do up till 3,500, but right now you are just utilizing 10% of the capacity, right?
Yes, sir.
Okay.
Dr. Nicola, you can shut down your presentation. Moving on to our next presenter, Dr. Alex Storm from Kastuba Medical College, Manipal.
Hello, am I audible?
Yeah, you are. You can share your presentation.
So, good afternoon, everyone. I'm Alex Tom, resident, Department of Pediatric Hematology Oncology, KMC Hospital, Mangalore. Today, I'm going to talk on my topic on improvement in care and maintenance of Portacat following the introduction of a care bundle in a tertiary hospital. So, Portacat is a type of indwelling central venous catheter commonly used in children who require long-term IV therapy. It is placed subcutaneously and is made up of two parts, namely the catheter and the port. The catheter is a soft, thin, hollow tubing which is tunneled under the skin, and the other end of the catheter is located just outside the heart or in the great vessel, while the port is a disc-shaped device which is placed on the chest, which is connected to the catheter. The most dreaded complication regarding indwelling central line is the central line associated bloodstream infection, also known as the CLABSI. CLABSI play an important role in the increased mortality, morbidity, hospital expenses, and hospital stay. According to CDC, CLABSI is defined as any laboratory-proven bloodstream infection with the central line in place for more than 2 calendar days after the onset of event and the date of insertion being the day 1. CLABSIs among Portacat patients can be significantly reduced by proper care and assessment by the nursing staff. The frequent development of Portacat-related complications such as blockages, infections, and extravasations led to the development of a care bundle to improve the care and maintenance in our institution. Now, coming to the literature review, a study done by Weinstein R. et al. From the United States of America has shown that CLABSI is one of the 4 main causes of hospital-acquired infections. In 2015, another study from Switzerland by Wagner et al. Has reported 4% CLABSI among the 48 children with Portacat. A significant reduction in CLABSI in neonatal intensive care unit from 10.3 to 3.7% after the introduction of a care bundle in children with central venous lines has been reported by Hussain A.S. et al. From a study done in Pakistan. And 71% reduction in CLABSIs across 30 neonatal intensive units, with statistically significant reduction over subsequent year by proper maintenance reporting of central venous lines has been reported from the United States of America by Fisher D. et al. Now, coming to the research objective, our main aim of this QIP or research was to look at the current practice of Portacat access and to look for shortcomings that are present and to rectify them through a systematic approach, which is pre-assessment, teaching with audiovisual aids, encouraging closed loop feedback and concerns, and providing the necessary help. Also, to provide a sense of confidence among nursing staff in view of Portacat procedures to training and thereby improving the patient outcomes. Other objective was to develop standard guidelines on the care and maintenance of indwelling catheters in a hospital and to reduce complications. The research methodology, we used pre-training and post-training design using the PDSA model, which is the Plan, Develop, Study, Act model. The duration of study was 4 months, and the inclusion criteria was the patients admitted in pediatric hematology oncology wards in KMC Hospital, Mangalore, with Portacat in situ. The ethical clearance was obtained from the Institutional Quality Control and the Ethical Clearance Committee. The residents of the department were conducting the QIP. We were trained by the pediatric hematologist oncologist who has been accessing and has trained for accessing Portacat since the last 15 years. We observed two sets of 30 procedures of accessing POTACAT by the nursing staff. Following the initial 30 observations of POTACAT handling, a care bundle was designed as per the standards of maintenance of POTACAT, which involved education, training, live audio-visual sessions. 2 months after the initiation of the care bundle, the second set of 30 procedures were observed. To determine whether the intervention on the primary outcome, which in our case is the improvement in care and maintenance and the reduction in CLABSI, the PART-3 test was used. A p-value of less than 0.05 was considered significant, and for analysis, SPSS software version 19.0 was used. This was the observation checklist which we used to assess the nursing staffs. The main characteristics being identification of the patient, checking the vitals, communication with the patient and the bystander regarding what's happening, preparation prior to the insertion, which we call as preparation prior to the insertion, asepsis technique, the needle insertion techniques, the bleeding back scenarios, the things to be checked and to be done during non-bleeding back scenarios, the removal techniques, local reactions, and the needle disposal techniques. Now, coming to the results, I put up a pre-intervention versus post-intervention results. So as we could see, we have achieved almost 100% efficacy in almost all the parameters we have assessed, and now I'll come individually to each. Now, coming to verbal consent taken and the communication with the patient bystander, it has improved from 83% to 100%. The involvement of second nursing staff improved from 23% to 60%. The drug expiry cross-checking improved from 26% to 89.2%. The adequate volume of saline being used after each access of POTACAT improved from 83 to 100%. The needle not touched by the care provider also improved from 86 to 100%. The positive pressure administration also improved in the same manner, while the heparin administration after each accessing of the POTACAT or removing the POTACAT has increased from 71 to 100. And looking forward to local signs of local skin changes, to look forward to any extravasation has improved from 66 to 100%. Coming to the discussion, this QIP showed significant improvement in care, reduction in infections following the introduction of a care bundle. There has been no new reported case of CLABSI in our department after the care bundle intervention. While there was a significant improvement in almost all the parameters assessed, involvement of second nursing staff while accessing and administrating drugs via the POTACAT in all patients could not be achieved. This was mainly due to the redistribution of the nursing staff to work in other areas, especially the COVID-19 wards. This is the first project from India on improving the care and maintenance of an indwelling central line. To conclude, this quality improvement project demonstrates proper training regarding care and assessment of POTACAT could prevent CLABSIs and extravasations. Thereby, it would result in improving the quality of healthcare and cutting the cost. Further PDSA cycles could result in significant reduction of the CLABSIs and other complications. These were the references used for our study. I would like to thank the organizers for providing me an opportunity to present our study. Thank you.
So since it's related to behavior, how are you planning to, I understood that for short term, you got a good result.
Yes.
100% result is kind of little unbelievable, because anything to do with behavior, since it's always difficult, that is something which has a lot of hindrance from the users. But even though we have to believe whatever the results which you have shown to us. So how are you planning to sustain the 100% result which you have got?
So yes, sir, very good. Thank you for the question. Our main plan is to keep continuing educating the nursing staff and the newly inculcated nursing staff regarding the handling of indwelling center lines. We are planning to conduct every 3 monthly live classes, and also we are providing them PowerPoints and other classes regarding how to handle the indwelling center lines and to prevent any blockages or infections in future. The regular training is the only way to look forward to it, and regular QIPs or to say audits to look forward to any infections and how the things are going is the only way forward to achieve or to maintain the results we have got.
What were the pre-test knowledge score levels of these candidates, these nurses?
So pre-test knowledge levels were somewhere, most of them were around 70 to 80%. We had analyzed various parameters. In that, we found out that inclusion of a second nursing staff for, say, while giving chemotherapy drugs or any cytotoxic drugs, they were not used involving second nursing staff. All such were very low. Cross-checking of drug expiry dates were around some 28%. Communication with the patient and the patient bystanders were somewhere around 80%. So roughly, if you say on average, all the parameters we could, pre-training only it was around 60 to 70% pre-training, and post-training it has almost improved. Except for few parameters, we have 100%. We have reached the 100% level in our training.
Were there any exclusion criteria for this study? You told about inclusion criteria.
There were no exclusion criteria, sir. Our study was mainly to look forward to in central line, CLABSI in kids with POTECATs. So the inclusion criteria was the kids with who were admitted in our wards with POTECAT in situ. Exclusion criteria are patients with no POTECAT in situ.
How did you collect the sample?
So it was not a sample, sir. It was an observation checklist which we followed. So the residents who were trained by the pediatric hematologist or oncologist who has been accessing and who knows about POTECAT for the last 15 years, he has trained us, and we were trained and we were looking at how the nursing staffs were performing. So it was just observation checklist. So we had checklists with us, which used to carry to the wards, or we used to have our iPads in the ward counters. So after observing, we used to mark the checklist. That's how we recorded the data.
Was it a standard one or validated one checklist?
It was a standard one, sir. We followed from the NHS guidelines regarding the POTECAT insertion and how they used their techniques. So that it was a standard checklist.
Okay, thank you.
Yeah.
Dr. Alex, you may close your presentation, please.
Okay.
Moving on to our next presenter, Mr. Vignesh from Ajay Institute of Hospital Management, Mangalore.
Good afternoon, everyone. I am Vignesh, a postgraduate student, Masters in Hospital Administration, Ajay Institute of Hospital Management, Mangalore. Me, the co-author of this study are Professor Vijaya, Dr. Amita P. Marla, and Mr. Shashikant. Title of my paper is Failure Mode Effect Analysis on Hospital Billing Process. Next, introduction. Failure Mode Effect Analysis is a risk assessment tool used to evaluate the severity, occurrence, and detection of risk priority number, which one of the most urgent problem to be resolved. In this study, billing process is studied and the various errors are identified, and FMEA is applied for the various errors in the billing priorities to need the reduce to harm to patient and staff. Next, objective of this study to identify the problems related to the billing process, to assess the different types of error that take place in the billing process. Next, it is a retrospective study, and secondary data was collected from hospital billing department for the period of 6 months, and various billing errors are identified. A universal sampling method is followed with 330 samples of billing sheet. Next, these are the findings which I have got it source of study. This graph and table indicates the departmental errors. That is, in ward, there is 257 errors. In ICU, 23 errors, and other errors 50. Total error is 330. Other error includes our cardiology, LT, OPG. Here, ward is having more error. Next, this graph and table indicates the error in different wards. The highest number of error has been identified in 3rd C ward. Next, this graph and table shows the errors in different ICUs. The highest number of errors has been identified in MICU. Next, these are the parameters where highest number of times the error are occurred. The graph and table shows that types of billing error. The highest number of the due to hospital charge, that is 262. The error due to doctor charge 141, due to service charge 126, due to consumable charge 119, and due to procedural charge was 48. Next, this failure mode effect analysis table shows the various failures mode are doctor charges, hospital charges, service charges, consumable charges, and procedural charges. The effect of all these failures modes are financial burden to the patient, hospital, or for the staff, and increase of the turnaround time of billing process. Severity score are given based on the effect of severity, which are very high, moderate, low, and very low, where 10 is very high, 8 is high, and 6 is moderate. The potential causes for the error: poor communication among staff nurse and patient relative executive, or it may be a new staff, lack of training, poor coordination, and due to workload. We have calculated the occurrence based on occurrence of the error. Under detection, again 10 scale were used, where 0.9 is couldn't detect the potential failure, 8 is unlikely to detect the failure before sending the billing, and 7 is likelihood that potential failures reach billing. Risk priority number is calculated multiplying by severity into occurrence into detection. Next, this is the billing process of the hospital where the error occurred in first 3 processes. Next, discussion. The current study disclosed the occurrences in types of departmental error that are classified. In ward error, different ward accommodation are taken. ICU error, different disciplines like MICU, COVID ICU, SICU, ITU, KTU, NICU, and PICU are taken for this study. Highest number of errors were identified in ward, that is 257 errors. The various types of error in the department are identified into hospital charges, doctor charges, hospital services, consumable charges, and procedural charges, where hospital charges constitute towards highest number of errors, and the errors are due to procedural are 48. These errors are further analyzed under FMEA table, and necessary improvements can be implemented in the most critical areas. Failure mode effect analysis help to identify the various potential reasons for the errors in the process of the billing and its effect, severity, probability of occurrence, probability of detection, and RPN has hospital charges 168, which shows the maximum concentration to be given. The analysis showed that hospital charge is having highest RPN and least RPN for procedural charges, that is 90. Next, the study concludes out of 330 samples, the errors identified were 696. The various errors identified are hospital charges, doctor charges, service charges, consumable charges, and procedural charges. The errors have happened due to various reasons such as documentation error, double entry, typing error, missing error. All these errors can be avoided by effective training, proper communication between staff nurse and PRE, and by cross-checking. Next, suggestions. There should be effective communication between staff nurse and PRE. Time to time, proper documentation must be followed in all departments. Double checking or cross-checking must be done. Effective training should be given. Any deviation in the bill should be sorted out immediately. Next, these are my references. Next, thank you.
Vignesh?
Yes, sir.
Am I audible?
Yes, sir.
May I know what is your operational definition for your problem statement, this error?
Yes, sir.
What was your operational definition for your term error in this study?
I did get you, sir.
See, when you mentioned error, there should be a research meaning for that. In this study, what do you mean by error in one sentence? That has to be defined first before proceeding to the study. You got me?
Mistake or inaccuracy or any mistake in the billing process.
That concept should be cleared before entering into the study, first of all. Okay, that's right. Can you conclude your study in 1 or 2 sentences? What is the final conclusion?
This study is total sample were 330, sir, and out of 330 samples, 696 error were identified. These types of error identified were due to doctor charges, due to hospital and consumable charges. This various reason that for error, documentation error, double entry, typing error, and indenting error, missing entries, etc.
I'm not very clear about the doctor charges, patient charges, and all. What type of errors were there?
If a doctor are visiting 5 times in a ward, means they are not entering 5 times. They might enter in less 3 or 4, or entering more 7, 6, 7 times like that.
What was the most common error which you have found in your study?
Doctor charges.
Doctor charges. How did your intervention help it? Can you explain your intervention? It's not very clear. Okay, Vignesh.
Yes, to implement, sir.
Okay, thank you.
Yes.
So moving on to our fourth presenter, Dr. Harshita Balasubramaniam from JSS Academy of Higher Education and Research, Mysore.
Good afternoon to the esteemed dignitaries present here, the student participants, the organizers and the honorable judges. I, Harshita Balasubramaniam from JSS Ahir, presently doing my MBA in Hospital Administration along with my co-authors, corresponding authors and other authors, present in front of you a study on comparison of wrapping techniques in Central Sterile Service Department of a tertiary care teaching hospital. As we all know, Sterilization is the quintessential part of maybe clinical or non-clinical areas in an hospital. Take, for example, operation theater. It should have the best sterilization environment. For that, we have different wrapping techniques so that can be used for wrapping the instruments of the surgery until it's put into use. The different types of wrapping techniques are textile wrapping, Steripack, and SMS wrapper. The objectives of the study are to evaluate the barrier effectiveness and penetrability of textile wrapping in comparison to the Steripack and SMS wrapper, to evaluate the cost effectiveness of textile wrapping in comparison to the Steripack and SMS wrapper, to evaluate the shelf life of all the three wrapping techniques. The cost effectiveness also has an interrelationship with the shelf life of the wrapping techniques. The research methodology was an observational as well as a descriptive study. The data presented in the research was collected from the CSSD for 6 months starting from the April to November 2021. Before starting the objective description, these are the fundamental characteristics of textile wrapping, Steripack, and SMS wrapper. The nature of textile wrapping is green handloom cloth. It can be green cloth as well. Steripack, polyethylene copolymer. And for SMS wrapper, it's spun bond, melt bond, and spun bond. The spun bond acts as a strength for the SMS wrapper, and melt bond acts as a barrier. Coming to the advantages, the textile wrapping can be multiple time usage, and it's very, very eco-friendly because the biomedical waste generation by the textile wrap is least as compared to the Steripack and SMS wrapper. Advantages of Steripack is it's suitable for the rubber instruments, and SMS wrapper, it's multi-layer protection as SMS I had mentioned before. The disadvantages of textile wrapping is we need to regularly inspect it for the tear or any and Steripack is disadvantages, it's single use and it's not eco-friendly. Same goes on with the SMS wrapper. The usage of all our single and multiple instruments can be used, and especially Steripack is meant for the usage of rubber instrument as textile wrapping, and SMS wrapper cannot accommodate rubber instruments. Coming on to the objective, according to the Type 5 3M Sterigac test, it was thus proven that barrier effectiveness and penetrability of all the three wrapping techniques were equal. And this is the cost effectiveness that is objective 2. The dimensions that are required for the wrapping of the instrument are textile wrapping 120 into 120 centimeter, Steripack is 75 into 75 centimeter, and SMS wrapper is 120 into 120 centimeter. These are the procurement sheets and procurement costs taken into consideration for the study. By arriving at the calculation of the per unit cost as rupees 2.33 for textile wrapping, rupees 37.03 for Steripack, and for SMS wrapper 20.28. So as we can see in this analysis, that textile wrapping has the least cost. And the third objective was shelf life. The number of uses of textile wrapping is 50 to 60 washes in an average, whereas Steripack and SMS wrapper are single use. This is the photo of textile wrapping for single instrument, textile wrapping for sets. There are certain guidelines mentioned on the packing so that any of the worker might know the expiry date, the machine number, and a hard copy of that is also generated. That's another photo of Steripack and the instrument packed in Steripack, and Type 5 integrating indicator and SMS wrapper. So the results goes as follows, that barrier effectiveness and penetrability of all materials are equal, and the generation of biomedical waste, textile wrapping is very eco-friendly. And according to the data and the calculations made, textile wrapping is having the lowest cost, like 2.33 in comparison to the SMS wrapper that was 27.08, and finally the Steripack that is 37.08. So I conclude my study stating that for major use of sterilization, textile wrapping materials may be used, and Steripack can have a limited use of sterilization. And not to forget, textile wrap has a low amount of biomedical waste generation, and in textile wrap and SMS wrapper, we cannot use rubber instruments. These are the references of this study taken in. And I would like to thank Amrita Vishwa Vidyapita for giving the opportunity, and AHA for organizing the event, and last but not least, JSS Ahir for being the constant support throughout my study. Thank you.
Ashita.
Yes, sir.
Am I audible to you? What is the widespread use in your hospital where you are coming from?
Sir, can you repeat your question, sir?
What is the widespread use of type of wrapping used in the hospital where you are at present trained?
Yes, sir. So wrappings can be used for single instruments. Wrapping can be used for sets, and the institute where I conducted the result for the gowns and surgical gowns and drapes, the wrapping were used, sir, as it is generating less biomedical waste, and it's eco-friendly.
Cost effective as well.
Yes, sir, cost effective. And it can be reliable as a person goes and investigates on a textile wrapping for its degenerating property. And we used 143 thread per unit of thickness of textile wrapping, sir.
Harshada, well presented. Congratulations. So
Thank
the
you,
doubt is that no, like with your study, what was you really aiming for? Because we know that textile wrapping, as far as CSSD is concerned, we know that textile wrapping is what we commonly use, except for few scenarios, as you mentioned. In case of rubber, we cannot use it. So anyway, we were using, and almost all of the hospitals are using textile wrapping only. So what was that in your mind when you take up this study?
So the institute where I conducted this study, they use textile wrapping more in comparison to Steripack and SMS wrappers, sir, in comparison to the other institutes where they encourage the use of SMS wrapper. And my main aim for the study was, if we use textile wrapping, we can be an eco-friendly hospital, sir, and even it is beneficial as cost, as well as it has an equal barrier effectiveness compared to all the three, sir. So I was encouraging the use of textile wrapping, sir. That was the ultimate conclusion, sir.
Harshita, you may close your presentation. Moving on to our fifth and final presenter, Shalva Abraham from JSS Academy of Higher Education and Research, Mysore.
Good afternoon to all the dignitaries, esteemed dignitaries, the judges, and the participants of this conference. Today, I will be presenting on a study on performance appraisal system in a reputed NABH accredited hospital, and employees' perspective about the performance appraisal system, which in fact impacts the employee motivation. And my name is Shalva Abraham. I'm from JSS Academy of Higher Education and Research, Mysore, Karnataka. So the first topic that I'll be talking about is performance appraisal, where the basic thing of performance appraisal is to know, evaluate the performance of the employees and give appreciation for the employees if they have performed well. It is a regular review of employees based on their job performance and to analyze the employees' strength, weakness, their growth, and also lack in the job. This also is a process where it gives feedback to the employees on how they are performing in their work, and will help them analyze where they can improve in their work to perform better and achieve the organization goals in a better way. And this might also help in achieving their personal goal as well. The next topic that I want to talk about is employee motivation. So employee motivation is also an essential aspect where it helps in achieving the organization goal in a more efficient way. This can also be known as a sense of achievement within the employee, where he finds a purpose in doing his job in a better way. Coming to the objectives of the study, the main objective of the study was to analyze the existing performance appraisal system in the hospital and to identify the factors considered in the performance appraisal system and what are the employees' perspective about the performance evaluation in the hospital. So the materials and methods is that to study the existing performance appraisal system, the existing records were reviewed through the records, and there were also reward mechanisms that was followed in the hospital. And the data on employee perception on the existing performance system was collected through questionnaire form, where the paper-based questionnaires were given to the employees, and the employees had to give out their opinion about the performance appraisal system. The questionnaire was submitted to both clinical and non-clinical departments. The responses from the study was for the survey form were rated using a 4-point Likert scale, where strongly disagree is 1, disagree is 2, agree is 3, and strongly disagree is 4. So the data obtained was analyzed using the Microsoft Excel. So the results is that the existing system that was present in the hospital, they used the performance evaluation used as a bell curve method, where here in the bell curve method, it is also known as post-distribution method, where certain tasks were assigned to the employees and they were observed on how their tasks were performed by the employees, and based on their performance, there was grading scheme. This was first introduced by Jack Welch of General Electric, and its bell curve method is a symmetric curve which forms in a bell curve shape. Here we can see that in the bell curve method, the first 10% are known as non-performers, where their performance levels are very low, and the majority of the employees fall under the average performance, where it forms as a bell curve shape, and this comprises of 70%, where the initial can be below average performers, then goes to average performers, and then it comes to above average performers. Then the next 20% are the top performers, where the employees give their best and their performance is outstanding. So here we see that in this existing method used, the process that was followed is that the task was assigned to the employees, where the employees had to perform the task based on their ability, and the employees were observed to understand how efficiently they are performing their task. Then based on their performance, grading was given, such as A plus A, B plus B, C plus C, and D plus D. So this rating is given, and then based on their rating, the employees were grouped to analyze their performance. And the high scored employees were rewarded and recognized so that they could be more motivated and continue to give their best performance. And the low performing employees were given more training, where they could understand their weaknesses and improve on the parts where they are lagging behind. So existing system is basically carried out by the HRM department. And coming to the next is the rewards and recognition, where there is 4 types of rewards that are followed in the hospital. That is GEM Award, Smile Award, Star Performer Award, and Wow Award. So this reward system was followed to motivate the employees to do better in their work. So coming to the first award, which is GEM Award, it is also known as Go Extra Mile Award. This award is given to employees who take up challenging goals and put their extra effort in their work. And the reward given is rupees 2,000 to the employees who have.
Shalva, your time is up. Yeah.
Okay.
So we'll move on to our judges.
Okay. And I just do 1 second. Okay, sir. You can ask me questions.
Shalva, am I audible to you?
Yes, sir. Yeah.
What are the objectives of your study, first of all? Can you please repeat once again?
It is to study the existing performance appraisal system and what is the perspective of employees based on the performance appraisal system.
But you never mentioned anything about the employee perspectives on the performance appraisal system.
No, actually, that was coming forward.
Can you please conclude it in 1 or 2 sentences, what you are about to tell?
Yeah,
you just explained different types of appraisal systems only, that's all, and the different type of awards. But what was the perception of the employees and what sort of a system was persisting in the institution where you took the sample?
Yes, yes. The existing performance appraisal system was bell curve, as I explained. But coming to the employee's perspective, there were different factors such as commitment, communication, decision making, employee development, job content, leadership, pay, performance, teamwork, training, and benefits. So all these were based on understanding how the organization was, helpful in employees' development in terms of achieving organizational goals and even personal goals of the employees.
What is your understanding about this 360-degree appraisal system?
360-degree appraisal system is basically a system where the opinion of the employees' influences are taken, where it can be their colleagues or patients or whoever they have encountered. So it's also the opinion about the third party that is involved in 360-degree method.
Okay.
No questions. Fine.
Okay. Thank you, sir.
Thank you to all the participants. We'll be declaring winners of the session tomorrow evening in our valedictory function. And may I request Dr. Ashish Gupta, sir, to please hand over the memento to our judges who took the time out.
Good afternoon to all present here. Hope you all had a good lunch. Now moving on to the first session of the noon, we are glad to welcome Dr. Venkataramaya, current professor of Operation Management, IIM Lucknow. He has published more than 20 papers which has been peer reviewed in international journals. His work on supply chain management are always inspiring. He's going to convey his talk on ensuring efficiency using technology, enable services in supply chain management. We welcome you, sir. Now, I invite Dr. Anup Daga, Assistant Professor, All India Medical Institute of Science, New Delhi, and Dr. Param Hans Misra, the CEO, to chair this session. Dr. Param Hans Misra is a CEO of IQ City Medical College and Hospital, Durgapur. We welcome you, sir.
I can say that I am a healthcare service seeker. So that is the point of view of my session also. So I want to know how many of the participants here in the conference now are with the MBA qualification, so that I can make myself comfortable, so that it will make sense. So since it is a virtual session, I am assuming that at least there will be a good number of people with hospital administration background as well as MBA. So what we are looking at here is how healthcare supply chains can make the care delivery more affordable or more. Is my slides visible?
Yeah.
Okay, right. So I have a good number of slides, but I will not go through every slide, but I will share this presentation so that people can use it. So I just want to ask some of the people, at least few people can respond to me, that how do you think that supply chain can help improving the care delivery? Is there any one or two quick students, particularly for the sake of students, you can put your thoughts on chat box. I will take a look at it later. So what I'm going to share in the next 20 plus minutes is that what is this supply chain and how these supply chains are shaping up the healthcare delivery, particularly in the context of hospital setting. So that's the focus of my session. So
I request you to put your slides on slideshow.
Yes, please.
Yeah, thank you.
Do that. Thank you. Yes. So I hope my slides are visible.
Yeah, very well.
Right. So the healthcare supply chains, how these supply chains can help to improve the efficiency, or rather you can call it as the cost reduction or improving the safety and so on and so forth. I will try to demonstrate these things through some of the examples that we worked on and also some of the examples that we are using it in our course of study. So the flow of my presentation will be something similar to this. So a brief introduction, etc., is a typical academic presentation. Please don't take it otherwise. So some examples, I will try to spend a good amount of time on explaining the examples. The remaining will be, just packaging. Right. So, yes, you all know the great man of our country, what Dr. APJ Abdul Kalam sir has said about health. And this gives you some idea about how health can be or healthcare delivery is so complex or complicated, and how various stakeholders can help to improve the care delivery. For example, Caliper is the best example of product innovation. So my session will focus on what are the innovations that healthcare industry can use so that it can make a lot of difference. For example, Jaipur Food is an example. Arvind Eye Care is an example. Kalam Caliper is an example. There are so many such innovations that have led to the affordable healthcare, particularly for India. And you all know that the cost of healthcare in India is also significantly high. How this, I think there is something wrong. Yes. So on one side, we have this road accidents kind of thing. So this many number of people are not killed even in any epidemic also. Maybe it is an exaggeration that you could see that the disease burden in almost all segments of the healthcare, be it communicable diseases, non-communicable diseases, and maybe road traffic injuries, and the new disease. I just want to ask you, what is that other type of disease that is the country like India is facing today is mainly due to the use of technology. Everybody is using this magic device called phone and smart devices. I would call that as the technology-induced diseases. Now you could see a lot of people, even during this the conference, a lot of people must be hooked to their smart devices. So I would call that as the technology-induced disease. That is no solution. Unless you change yourself, or the behavioral change. That is the point I want to drive. And this gives you some idea about the complexity of healthcare delivery in India, and particularly the complex healthcare delivery system that has been faced in the Indian context that needs a lot of revamping. So that's what is happening. You could see Ayushman Bharat and new schemes and so on and so forth. So this gives some idea about healthcare spending in developed countries versus the other countries as well. But India is not figured anywhere here. And below, it must be much below 500 or less than that per capita spending. So in spite of this spending, the healthcare, health status of these countries also not something very great. This COVID has really proven that. So this shows some idea about the healthcare spending both by public and private. And I'm happy to see this conference happening in Kerala, and Kerala is on the top of the list. And of course, you could see that though the healthcare stats of Kerala is good, but during this COVID time, even Kerala has suffered a lot, or rather, one of the most suffered states in the country is Kerala, as you are aware. So there is a lot of variability in terms of the spending or the infrastructure, etc. India comes with a lot of challenges. So what you need is the management solution. That is the point I want to drive. So is a medical solution, political solution, scientific solution. Now what you need is the management. Can management solution fix this healthcare or to some extent possible? And that is the reason why we are here. We are trying to understand how healthcare supply chains can help to reduce this cost and improve the access and so on and so forth. So how many of you are, of course, every one of you are aware that there is a balance sheet for hospital as well. Every hospital has a balance sheet. This is also a balance sheet of one of the chain of hospitals in this country. Of course, this balance sheet is way back in 2008-9. And you could see, if you see today, the material consumption is one of the highest. And if you see in one of our studies at the largest hospital in Delhi, the 4 times of consumption is the inventory. Just 4 times plus is the inventory. So is there any way that it can be looked at and seen how this can be reduced? This point I want to drive is that there is a lot of scope for improving the healthcare delivery or reducing the cost, improving the quality, etc., by focusing on supply chain. So that is the point I want to emphasize. And improvement in healthcare infrastructure and the use of digital technologies. And let me put it, the way forward for improving the care delivery is the collaboration. As you are all aware, that there was also a wonderful program in the morning session. One of the speakers, I think Alexander, was mentioning that there is a digital technologies healthcare program is coming up. I must also share with you that IITs and IIMs and AIMS kind of organizations are also coming forward to address this gap, and the collaboration is happening in a big way in the Indian context as well. Of course, that is happening very much effectively in other countries, particularly developed countries. So here, if you see, even I must share with all of you, those of you who are interested can look at our website also. With Apollo MedSkills, we are launching a program on healthcare, executive program for healthcare professionals. Those of you who are interested can take a look at it. And if you need any further details, you can reach out to me. So what's happening is, on one side is this. The other side, there are a lot of trends that are happening in the world of, in the healthcare world. So one such trend is how digital technologies is shaping the healthcare delivery. Thanks to COVID, I would put it as the COVID is the prescription for change at all levels. So it is the COVID-led healthcare delivery models that are becoming much more vibrant and maybe robust in course of time. So during this COVID time, we have seen a lot of challenges. A lot of people lost their life, and just even the oxygen, the flow rate change in the oxygen also led to the chaos and maybe the loss of life. So what are the opportunities, as you could see during this COVID time, is building permanent technologies and operational transformation by adapting to new practices, work from home, online education, or hospital care, healthcare beyond hospitals, and so on, so the home-based care. And the long-term cross-border healthcare collaborations, that is for treatments and R&D collaborations, are also happening. As you could see that the kind of collaborations that happened during COVID time, manufacturing industry coming forward to assemble ventilators and 3D print, HP and other printing companies coming forward to print the components of various medical equipment using 3D printing and so on and so forth. As you could see that there are a lot of such collaborations happened during this COVID, and the COVID emergency has brought a lot of new things or new models of care delivery. That is the point I want to stress here. So the impact of COVID on healthcare, I don't need to stress specifically because everybody has gone through, and today we could see all of us both in mixed mode mixed mode here, both physically and cyber kind of systems. So these what physical cyber systems are going to the way forward. And if you look at this, what is most important thing is the flexibility. And on one side, and if you look at the supply chains, particularly in the context of supply chain, either it is food supply chains, retail supply chains, or healthcare supply chains, it is the resilience is the need of the hour. I hope you all know what is resilience. Resilience is the ability of any system to come back to the normal after there is a crisis. So that is what is the resilience. And this resilience has been built across the organizations, across the globe by using digital technologies. We'll tell about, go through a few examples around that. Right. So there are a lot of opportunities through COVID and the use of military logistics and role of e-commerce. What is that we can learn from military logistics? Now we have a lot of people in this conference itself that the people who are delivered something very significant in the context of crisis or disaster management kind of thing. So there are a lot of lessons that one can learn from civil supply chains, military supply chains, and including railway supply chains. In India, during this COVID time, all supply chains have emerged and collaborated very seamlessly. That is a great opportunity, and we have demonstrated that in a very big way. And you look at the 12 days, within 12 days or 9 days, a big 1,000-bedded hospital has been built in Delhi by DRDO. So the capabilities of DRDO has been put into place, and you can see how private players came forward. That is where the public-private partnership, or whatever you can call it as. So the robotics is playing its role, and 3D printing, blockchain, and of course, gamification. You could see that, and chatbots. And by and large, one thing that is now new area is biosafety and security in your supply chains. You have brought some item, but that has come from, let us say, a meat has come from affected area. So how do you ensure that biosafety? Today, supply chains have gone beyond digital, and it has become microbial, and microbial safety and precautions have to be designed. When you design a supply chain, is your supply chain biosafe? Biosafety standards are started coming up in the supply chain context. So you have seen how companies have changed their portfolio of operations. The apparel companies started manufacturing PPE kits and maybe masks and so on and so forth. And sanitizers, the companies which are manufacturing beverages have swiftly shifted to manufacturing sanitizers and so on and so forth. So these are some of the things that we could see during the COVID time. So apart from this, there is also digital technologies. So just the next few minutes, I will tell around these digital technologies and some framework for digital, how this information technology can make the difference in the areas of telemedicine, social media, mobile apps, video conferencing, public addressing systems, and so on and so forth. Kerala is the best example where the film industry people started coming and interacting with the general public, and all that innovations are happened during this COVID time. And this can help in a big way to improve the quality as well, because it's getting recorded and there is a facility to go back and look at what is happening and how it is happening. So some of the examples that we could see, the way particularly during wave 2, Mumbai model is the best example that we can see how technology has been used, and including IIT Bombay, the way they have worked together to develop IT systems for integrating that. And a large public hospital system like in Delhi, how hospital network came forward through technology. And the Tamil Nadu model is one of the robust models that we all know, and how this has changed the way care is been delivered in the public health setting. And UP Medical Corporation also. I hope you all know that almost every state, major states are having their own corporations, particularly medical supply chains. The government has realized the need for medical supply chains, and that shows the value of the supply chains across both the public and private organizations. The railway hospital, similarly, and the way the PPE kits have been manufactured during this time, and ventilators, the startups, the smallest company going with a collaboration with the biggest of the biggest companies like manufacturing sector and so on and so forth. The oxygen is the best example to understand how we have managed the oxygen supply during this crisis time, including medicines, diagnostics, and another important thing is the waste management. These are the areas where we can make the difference by using supply chain issues. Let me just quickly run through some of the examples. The new urgency is the one model where the mobile-based smart technologies have made the difference. So what is their business model? You look at these things, now the health is getting really complex by making these technological advances into the picture. So this is one example. And iCure with whom we are working closely is developing these solutions for rural for a long time during this COVID time. It has helped many organizations through their tele-platform network. So the service mix and the business model of this company is the one which we can look at and learn something from them. So similarly, this is the one example where we could see how oxygen was track and trace. The companies that have developed for understanding what is happening to the oxygen, where is it available, in which location is available, and how these allocations can take place by taking into account the digital technologies. So these are some of the examples that I want you to look at. So if you see this, the oxygen supply chain through SCORE model of supply chain, how they have integrated this with the information technology. There are a lot of options thanks to this technology. Of course, you all know that during this COVID time, the benefit, financial benefit to a lot of people has happened mainly because of the Aadhaar. So country like India, the Aadhaar was the biggest enabler for digital healthcare. I think the country like India is not yet has not yet harnessed the benefit of Aadhaar for digital healthcare. I think there is a huge scope for this. So in terms of healthcare supply chains, if you try to understand from oxygen, let me explain through this example. The high variability in demand side and lack of coordination among the stakeholders. These things were really addressed by technology platforms. They know that they are tracking and they know where is the oxygen shortage, where are the beds available, where are the bed shortage, and how these resources can be timely allocation of resources, efficient allocation of resources was possible only because of the technological advances that has happened in the field of healthcare as well as allied fields. And the shortage of skilled manpower, you could see that how quickly people have been trained using digital platforms. Let me tell you that these digital platforms helped very big way to train these house surgeons and others quickly on what to do and what not to do. So the digital platforms helped in a big way. And the allocation of patients to different locations based on the bed availability and based on the necessity or the criticality of the care. So the improved access to medical supply chains is very strongly demonstrated. That has all happened because of the robust medical the information systems or IT technologies that were possible. And the restructuring of supply chains, including logistical and cross-functional risks, was able to manage. This gives you a clear picture about how oxygen supply simplification or efficient allocation of oxygen and distribution helped this during this COVID. And hub and spoke model is well known both in healthcare and outside healthcare settings. So what I want to convey in this slide is that healthcare organizations are readily using these supply chain concepts or supply chain mechanisms and is seeing the results very much. It is all possible because of the two reasons. One is the necessity, another is ability to use the technology platforms. That necessity means here is the COVID. So COVID is a big prescription for change. So that's my point. So some of the innovations that have happened during this COVID, I'll just skip these things because we have already seen the examples are like Apollo, AIIMS, all these hospitals have used all the big innovations that was led through digital technologies and including startups, the way they have come up. So there are few other simple things I want to show. that on the medical devices side or the equipment side or the other peripherals. So as you could see that these technological changes that are driving the healthcare delivery models. So this is another example, smartphone technologies, apps, and telemedicine. Today, some of the governments like Telangana and a few other governments also started using drones for vaccine delivery in remote areas. So this gives you some idea about how the telemedicine has changed the way the care has been delivered. One of the most important things in telemedicine is the managing the supply chain due to telemedicine adaptation. The medicines can be delivered, but how? What are the regulations as far as the drones use are concerned? So this gives you some idea about how the telemedicine landscape is changing the way the care is being delivered. On the other side, open sourceware, softwares are all available for free. So people can build their own systems and processes very easily. So these kind of innovations are also changing the way the care is being delivered. On the one side, cloud computing. So the information technology cost has drastically reduced due to cloud computing. So another thing is the way these things are happening, the affordability of care delivery has increased tremendously. This is the evidence. Software as a service. Now you could see care has been delivered. The business models have changed. The care delivery business models have changed drastically due to the advent of these technologies. So this is from Arvind Care digital technologies adaptation model. I must tell you this. There is a lot that can be provided by harnessing the technological capabilities. The people need to focus on what is the purpose, reaching out to the community care. Particularly, Arvind model has become very robust, mainly because of their the grassroots level model development, looking at the purpose and the problems that they are trying to solve and the perspective. This is what is the, I would call it as 3P of healthcare delivery model that we can learn from Arvind. So there are also artificial intelligence, machine learning algorithms that are shaping up the care delivery. 3D printing example is ventilator components that got printed, and so many other things also got printed recently. And the blockchain is going to make much more vibrant, and the blockchain applications particularly can help the traceability and authentication of the records, smart contracts, all that stuff. So the blockchain is the future for healthcare, and of course there are a lot of startups who are using very big way. So the last piece of my message to all of you, this is my favorite slide, which I have shared earlier also. I don't want to skip that, but what I want to convey here is it's not just sufficient to have a technology and everything. You need to change the way you conduct your business. That's what we call it as a business model innovation. And you have seen the product innovation, process innovation, service design and delivery innovation. These are the peripheral, but heart of these things are the business model innovation. The business model innovation, I mean the way you conduct your business. So here you could see the GE, the way they have changed their product portfolio through the research. This is the example of product innovation. And the process innovation could be Arvind Hospital, how they have changed and become efficient in terms of care delivery. So let me talk to you another next 2-3 minutes, and then I will stop. So there is all these innovations are one part, and unless you change the business model, the way you conduct the business, either it is healthcare organization or a commercial organization, what is core to anybody is the way you change your business model along with the time as well as the technology. So here, very simple example, and everybody is online. Almost everybody is online. Both offline and online services are available, including for e-commerce companies. Now they are coming out with physical infrastructure as well. So the one question here is that there are 3 options for buying a simple magazine called Economist. If you buy print subscription, it is $125. If you go for web subscription, it is rather $125, and the only 1-year subscription for Economist is $59. So this is what is pricing. These all lies at the pricing. That is what we talk about affordability in healthcare. How do you how do you improve your care by improving your pricing mechanisms? So here, if you go for options in these three, since in the due to want of time, I am not going for a poll. If you choose these options, there are number of people who can choose either option 1, 2, 3, and the result shows that these options, the second option is the least preferred option, or nobody preferred this option. That is what is the reality. So since this is not being opted by anybody, I can remove this prescription or that particular option. Let us say a particular option of care delivery model. This is true in almost in every aspect of business. Just by removing, you can change the number of options from 2 to 3. If you do these options, that is number of options that have been generated or offered to a client or to a customer. That is the point I want to drive here. The results are completely upside down. So I'll show the results of this option. Here you could see in case of first scenario, when you offer 3 offers, you will get 16% people opt for option 1, 0 for option 2, and 84% is for option 3. It is very obvious. There is a big value add. This is true for healthcare as well. What is that you are adding to your service? Basic service. So when you remove this option, which is not selected by anybody, is been the second option. The moment you offer only 2 options, the options selection has become reverse. 68% of the people gone for option 1 and nearly 30% of the people gone for option 2. As a result, the revenue of the organization has gone down by 30%. This is what I mean. The people are same, the product is same, the options just 3 versus 2. How do you design your system? How do you design your supply chain? How do you design your business model? How do you align these business models to make what you want is the crux of the problem. So I leave at this stage. So this is what I call as the supply chain innovation or a business model innovation. How you integrate your business models with your care delivery is the need of the hour. So the future of healthcare, you all know, and this is all the smart devices driven. And this is where apps, this is patient driven, outpatient driven, or physician, and so on and so forth. These digital technologies is becoming the center stage. So the next important thing that you could see is the care is happening at a doorstep or at your home. So home care or care delivery beyond hospital walls. When you do this, how you manage your logistics and supply chain. So that is going to be a big nonsense. So or rather, that is going to be a big opportunity for others. And the supply chains are going to be provided by the third parties. So what I want to convey at the end of the day is there is a lot of scope for customizing your solutions. What is being followed by Apollo in Tamil Nadu may not work in Delhi, or what is working in Tamil Nadu public health may not work in UP. These are true. These are localization. What is more important today is how do you localize? How do you localize? For example, AI, telemedicine. How do you customize to the local needs, particularly in terms of language alone? We have seen a lot of examples that the digital technologies working in the regional languages. So that is where the future. Now these are some of the areas where I thought it makes sense. So focus on people, processes, technologies, and of course, don't leave the business models innovation. So with this, I will stop here. And some of the conclusions would include that make sure that supply chain is core of your organization, be it a healthcare, be it e-commerce, be it a mobile company, or it is any company for that matter. There is no company, no organization can survive without supply chain. Supply chain is like a spine of organization. That is the point I want to drive. And the future of supply chain depends on the collaboration. So this is my last slide. How do you improve the skills? Change with time. So I stop here, Professor Anup and Vishwaji. Sorry, I've taken a couple of minutes more.
Thank you very much, Professor Venkat, for wonderful elaboration. It was really very learning. Of course, supply chain is the most important part of any healthcare, because whatever surgery anybody wants to do, If the implants and consumables are not available, he cannot do it. Whatever medicine a doctor may prescribe, if it is not available, patient is not going to be benefited. So as you rightly said, it is the spine of any healthcare or any organization. So if there is any questions from the audience, most welcome.
So
online, offline. Yeah, please.
So there's a question from our participant.
Yes, please. Yeah.
Let us know the feasibility of BPR in resource-constrained public healthcare facilities.
Wonderful. This business process re-engineering is a very old stuff. Let us say this is somewhere around the 90s or early 2000. And this business process re-engineering was coined by the IT professionals. And today, more than that has happened. The process reorganization, we call it as a process reorganization or a process restructuring, is very much useful for public health. If you want to know more about business process re-engineering or supply chain process simplification, Tamil Nadu model is the best example to learn. And of course, including Arvind model. I always, praise this Tamil Nadu model. Either it is a public health delivery model or a private health like Arvind model. I think these two are more than sufficient for anybody to understand what this is public health facilities. For example, how do you ensure that quality drug is being delivered? Packaging. Just for public versus private, packaging itself is a big issue. How you change that public system, drug delivery. I hope I have answered your question. Yes, please.
Last question. Director of Supply Chain in Jammu.
Yeah, Dr. Venkat is known to me. Dr. Venkat, I would like to, have a small comment.
Yeah.
Actually, supply chain management was tested during the COVID.
Yes.
And most of the time it failed. Most of the places it failed.
Yes.
And if the government of India would not have innovated, I'll tell you how they innovated, then the things would have been very difficult.
Correct.
Right, you rightly said that the oxygen manufacturers, there was shortage of oxygen. There were very limited manufacturers of the cylinders. You must be knowing there were hardly 2 in the entire country who were making bulk cylinders.
Correct.
So one of them was I think blacklisted because of the some reason by the government of India for non-supply or something like that. So you can imagine the requirement vis-a-vis the availability.
Correct.
So in supply chain management, these two things are very critical. Then another thing is that most of the items which we required during the COVID were not being manufactured in the States.
Correct.
And third thing was there were some drugs or the logistics which were being manufactured in the different states were being piled up by the states. They were not allowing these medicines, even the critical medicines, to be taken out of their domain, and the government of India has to intervene. So what government of India did was excellent. They, took control of everything. Everything was pooled at one place. And then depending upon the number of cases in the different states or UTs, the supplies were released, that too free of cost.
Correct.
And especially transportation of the logistics, all these supplies during the time when there was complete shutdown was a much more bigger challenge.
Correct.
I still remember because I'm heading a corporation, Jammu and Kashmir Medical Supplies Corporation. The Air Force helped us in taking the supplies which were given to us at Delhi, and from Delhi, Air Force picked it up and gave it to us at different places. And then how we managed to take it to the different districts, being remote and hilly area, was another big challenge. So supply chain management per se is not a very simple thing, and you give a very good presentation. But if you see it from the other point of view, in actual management, it is entirely different. And especially now, I think after the COVID, it was tested and it has improved a lot. Especially the manufacturing part has come up in the country, and there are a lot of local manufacturing going on. So hopefully we are not going to face that challenge once again. But it was very difficult time. Thank you.
So let me add just one word comment on this. As you rightly said, that during this emergency time, emergency brings everybody together, be it civil, military, railways, everything. During this COVID crisis time, you could see Air Force flights used, as well as the trucks, as well as the railways and the commercials, and including the commercial trucks are being carried by Indian Railway wagons. So the train carried, these things have happened during wartime. This is what we say in my class also, that, what is that we can learn from military logistics and what civil can give to military, and what these two can learn from Indian Railways kind of thing. So the collaboration is the key, number one. Number two is, as you rightly said, the leadership, the governance, leadership of the government of India is a great example. And they said, nothing doing, we know everything. Centralized planning, decentralized execution. If you want to put it, what is the key to supply chain success is a centralized planning and resource allocation and decentralized execution. What worked best in this context during COVID time? In one sentence, it is a centralized planning and decentralized execution and the leadership. Of course, technology is backend is there. Yeah. Leadership matters.
Anup, can I just have a word?
I think we must thank you, Professor Venkat, for such a vivid talk on using technology and ensuring efficiency in supply chain management to hospitals. One thing you said rightly also, that with times when they are changing, we have to ensure technology, but ensure efficiency at every point of time, because India, our country, is a resource poor country. Another thing, one thing we highlighted, that technology, while we are ensuring efficiency, but technology itself may be leading to the new challenges of disease for us. And on a lighter side, something like technology-induced diseases. Everybody is using the smart device also. So leadership
has become a new disease.
Yeah. Maybe in the next SASH also we can have a talk on this technology-induced diseases, something like this. I'm just joking.
So I think Jektar sir wants to say something. Yes, sir.
Yeah, not taking much time. First of all, Professor Venkat, as usual, a great talk, very enlightening, very insightful. Thank you so much. And secondly, you highlighted how the military logistics works. There are two things in it which sort of are important as far as military logistics is concerned. We always work on the worst case scenario basis. That is one. And the second is the contingency planning. So, one works in crisis and one works in routine. So both the things are important. And this is something which, we did see some of it happening during the COVID crisis, because even the Indian Air Force helped, if you know, they carried the oxygen generation plants from abroad into the country. So now, so the third point which I'm trying to make, while the going is good, there is a lot of, sort of lesson for everybody to build capability during that period. That is very important. And some of the states which had built up the oxygen generation capabilities during the period between the first and the second wave did well. And one of the examples is that Nandurbar, district in Maharashtra, where one of the, district collectors had foreseen this problem, incidentally or accidentally, or fortunately, he's a doctor, who had gone into IS, and he was able to give the best services to his thing. So I think these are a few of the things, but I'll leave it for another time, possibly another talk from you on building resilience into the supply chain, management.
Sure, sir. Thank you for your valuable words.
Thank you. Thank you very much. And my compliments to you for a great presentation. Thank you.
Thank you very much, Professor Venkat. Pleasure listening to you.
If there are no more questions, I think we can close the session.
Great speech. Now, on behalf of SASH 2021, we would like Dr. Venkat Ramaya sir to accept our token of appreciation.
Thank you, madam. With a great, with all the great appreciation from your side, it's my pleasure. Thank you all.
On behalf of SASH 2021, we would like Dr. Anup Daga, additional professional, AIMS, New Delhi, to accept our token of appreciation.
Thank you, ma'am. I accept. Thank you. It's a pleasure.
Now I invite Dr. Dilip Kamath to give the memento to our chair.
We have with us Mr. Mohammad Zafar Ali, CEO, Whitehall Hub, Singapore, to talk on the topic entrepreneurship in healthcare, health innovation, and digital healthcare. Mr. Mohammad Zafar Ali is an expert management consultant with 20 years of consulting exposure, advising organizations on a variety of business transformation initiatives like digital innovation and transformation, automation, etc. With great pleasure, we welcome Mr. Mohammad Zafar Ali for sharing his expertise knowledge with us. Welcome, sir. We would like to welcome Colonel Dr. Vishal Marwa, Principal, Amrita School of Medicine, and Dr. Ashish Gupta to chair the session.
It's all okay? Yes, Dr. Mohammad Zafar Ali. I think this is a very relevant topic for the younger generation, the students who are sitting around attending to this two-day conference. Entrepreneurship is the buzzword around startups. You are talking on a very relevant topic at this stage. Please start your presentation, sir.
Thank you. Thank you. I've given 30 minutes for this discussion. Let me split this into 20 and 10. So for the first 20 minutes, just bring up key messages from my my today's session, and then we can have a more interactive session of question and answer after this.
That will be great.
So objective of today's session, and I was hearing that Professor Venkat, he has covered tremendous amount of digital innovation space, which I think is a compliment to what I'm trying to bring to the table. So my today session has three key messages. Number one, I think innovation-driven entrepreneurship has always been an important part of any emerging economy. And today in healthcare is much more required now than ever before we had. And by the way, innovation is not new to healthcare industry. It has been there forever. But the way the technology has changed the game, I would like to bring that message to the table at how innovation is pretty much required in Indian context. The second message which I would like to share today is what's happening on healthcare innovation space across the globe, locally in our region in Asia and in India, and how the startups are disrupting the traditional models for good. Professor Venkat has already touched on these topics. I'll briefly talk about that. Probably the most important point that I would like to spend majority of my time is funding part. Now, funding, which was the biggest obstacle in terms of any startups or entrepreneurship ecosystem, is no more an issue for the right idea today. The amount of money that is going into the healthcare startups, not just globally, but also in India and in Asia, is unprecedented. So let me spend some time with you to go through these three messages with you guys today. Now, why do we need innovation entrepreneurship? Prof and other speakers have already talked about a number of other areas, the way they have highlighted that entrepreneurship is very much required. Let me highlight in the last 5 years, healthcare system in most countries, not just India, but most of the countries, including the developed countries, have come under increasing pressure in terms of cost, demand, supply, access, and expectations from the patients. So this has pretty much put the foundation for the larger space of innovation that we are now going to talk about. Now, the reasons. as cost has always been an important part of the entire industry as such, but the escalation of healthcare costs is now one of the major trigger points. Growing population, more expensive medicines, demand for diagnosis, and increasing staff cost and reducing the supply. So that has been one of the pivotal points for, like we mentioned earlier, that in terms of crisis, the discoveries will happen. And this is one of the major crises that is happening in healthcare across the globe. And then there is a complete change in the patient expectations. In the past, doctors were seen in a completely different perspective. Today, the hospital industry, the service delivery ecosystem, the payer ecosystem, all of them are coming together and raising the expectations from patients. Now, patient expects and demand, rather than expect, a better quality care today. They need that a patient-centered approach rather than a very silo approach that we used to have across the globe. So then you have the last point. The care complexity itself is being dramatically changing. The aging population is not just an issue of our developed world. It's going to hit us very soon in Asia as well. Rising prevalence of multiple long-term conditions is another point that has triggered this entire crisis. So considering these are the three distinct areas of where the pressure points have been pushed for healthcare industry across the globe, entrepreneurship is needed in not just to make an incremental change, but a dramatic change. That means to completely overhaul the healthcare system the way it has been operating for the last 100, 150 years. And that's how we are seeing it today. We are in early stage of the innovation camp. I must say that healthcare is basically a follower rather than leader in this, in terms of leveraging technology and digital space. Like fintech has taken a much more longer leap ahead of the time. The e-commerce business has taken a much better advantage in the early 2000s to till today, last 15, 20 years. EdTech is coming up very strongly, but healthcare is catching up. So as a community where we belong to today, we need to start looking at how do we bring this two together. Now, I briefly talked about patients becoming more like consumers. I think all our entire innovation in digital space of healthcare is more or less addressing this one single point, how they take care of the patients. And this has been there forever, but now it has become more a service-oriented topic than just a care topic. The reasons are very clear that today's patient is much more informed. There's a WhatsApp university that happens parallelly. There is a blogs and internet, Googles, and whatnot. So the demands that are created by patients is much more sharper and clearer today than it used to be in the past. So some time ago, about 2015 or so, we did a prediction that how will the healthcare system will be in 2020. And these were the 3 points that we highlighted 5 years ago. At that point, we said that individuals are better informed about their own genetic profile, their health status and risk. Informed consumers demand specific treatments and best services. Fully engaged with quantified self and prevention and agenda, and use the information data to get the best in treatments. Now, this was a prediction made 5 years ago on the basis of the technology changes that was happening at that time. Today, we see that evidence happening. There is an increasing number of people who are comfortable with consulting doctor over a video and a Skype call. One of the good part of this entire pandemic that we have been facing for the last 2 years is that it has accelerated the process of acceptance. The consumers accessing to the electronic health record has become pretty much a norm today, and is continuing to increase as we speak. Consumer willingness to pay has increased. So you can see that it has already saw a dramatic 3-fold increase with almost 40% of consumers today strongly agreeing that they are willing to pay for health. Earlier, it used to be more of treating a disease Today, they are willing to pay to prevent the disease, for a mental wellness, for healthcare, to avoid a situation that they're going to get hospitalized. So there is an increased awareness which has been noted today in our surveys that we did in recent past. And across all the telemedicine platforms, the satisfaction rates are above 75%. Same thing when we did it around 3 years ago before pandemic, people were too much hesitant to have a telemedicine platform, including the physicians who are giving the care services. So that survey has now brought to the table that today they are more satisfied with using the digital rather than going to the conventional model. So consumers who self-pay for the service are more satisfied across the board, especially who are not covered by insurances, are not covered by any payers. But considering this backdrop, we now need to see what's happening in on the healthcare innovation space and how the startups are disrupting the traditional models. Like I said earlier, the number of speakers today has highlighted a lot more innovation than what I'm going to bring it to you as an examples. But let me just touch upon some of the areas where the healthcare innovation is happening today. Right? Just to be precise, as I was telling earlier, that innovation is not new to healthcare. Medical devices has always been a central part of healthcare delivery in not just Asia, but across the globe, not today, but last 200 years. Even from the day the stethoscope was discovered, till today where we have MRIs in the rooms of doctors, the medical devices have always been the center point of innovations. But what's happening around that is the digital health. Now, digital health is a very vague word. If you look at it, it's a very broad word, I would say. But to break it down, what the difference between the medical devices that we used to have in the doctor's room is now being connected. And that information is creating the tremendous amount of access and ease of delivering the services across the board. So the digital health has complemented the innovation that was already happening in the medical devices space. Now, combining these two together, telehealth has been a new phenomenon. I would say that, as I was saying, that 75% of the customers which using telehealth has now been rating it as more satisfied. This is one space that things are taking to the next level. And again, to a large extent, the contributing factor has been pandemic that has accelerated this process. But then, very interesting part, and I'm going to share very soon, mental health and wellness tech is now taking a prominent space where the money is following from the investors. Now, why mental health and wellness tech? Majority of urban population who are city-based are now having a very good access to internet, devices that are affordable, that can be smartphones like handheld devices. Plus the awareness that they want to be healthy and have an active aging in their life has contributed to a major push in creating a wellness technology as one of the area that most of the innovation is now being funded. Biopharma has always been there. It's not something that is new, but biopharma is now taking in a new shape. The genetic mapping, going down to what could happen to you, more of a prevention rather than developing new drugs. That's the space that biopharma is placing the new area of innovation in digital space. Of course, the digital therapeutics has come after care, after the major incidents of surgeries and all that is now being translated into digital therapeutic space, which is also getting a lot more attraction. Last but not least, the health IT. Now, health IT is a space that hospitals have been using it quite efficiently for a long time. HI systems are not new to the healthcare systems, but that connectivity to these systems among different hospitals and to the larger public environment has created that information on hand for the patients to carry their EHRs across the board. So health IT, which was used to be a central part of a hospital, has now become a broader topic, which is connecting patients, doctors, and hospitals among themselves as an ecosystem and a broader healthcare delivery system. So the health IT is another big step of where the money is going in terms of entrepreneurship and startup stuff. Now, I was looking at what's going on with the money, where everything is money follows, and wherever the money is going, that basically gives some indication of where the actual innovation is happening. In terms of clinical indications, if you see, mental health has taken the largest share of the funds that had happened in 2018, 19, 20, even today. $3 billion is being funded to early stage startups in the mental health space, followed by cardiovascular diseases. Diabetes is taking center stage. Not just diabetes, most of the chronic diseases are taking center place. Primary care, and then oncology and substance use disorder. So if you see the money where this is the largest being spent, it is on the space of the mental health, which is something which is new and it's coming to the space where we are operating today. Now, healthcare startups have had their fair share of failures. Now, having been in this ecosystem, personally involved in investing in startups for a very long time, as an investor, as an operator, I have seen a number of failures that is happening in healthcare space. And this is not very specific to healthcare, but generally the health startups do fail. And healthcare startups had their fair share of failures for not targeting the real consumer problems, but just serving what is possible through the technology. Just to give an example, I sit in a lot of these platforms where we evaluate the startups for fundings. My general observation has been this: for every 1,000 ideas that knock the doors of incubators, early stage accelerators for initial funding for the seed stage, only about 500 of them get seed funded, which is about 50% of these ideas get some form of seed funding, either through BARC or through institutions or through private angel investors. Out of this 500, only about 100 make it to the market, which means they are generating some form of traction, either in terms of their service being accepted by the customers or they're able to generate some money in terms of revenue. And barely 10 of them get serious money. Or if you say in terms of making it big, it's only 1 or 2. So we are talking about 2 out of 1,000 ideas that are being actually seen in the public eyes. So for every 2 successful startups that you see, you can easily count that 998 of them have failed behind the scenes. And then we started to realize why they are failing. And this is an important point. We should bring it to our budding entrepreneurs who are in the room and who are listening to this webcast. 35% of them are failing because whatever they are creating, the product or service, there's no market need for that. And of course, 38% of them runs out of the capital. I want to touch upon the capital. So the question is, why 35% of them are unable to make their ideas work for the region? Simple. When we started looking at these factors, we realized that most of these startups does not have clinicians in their team. Doctors are not part of this. Physicians are not part of this. This is a bunch of IT technology guys who see there is a fancy new technology that comes in the form of blockchain, AI, big data, and they try to create a solution, assuming that that solution will create some impact with the in the broader ecosystem. However, if a clinician is part of the healthcare startup, the success rate and the ability to create an impact on a larger scale on healthcare is at least 100 times more than a startup which is addressing a healthcare problem doesn't have a physician. So after having done this study in numerous forms, we realized that clinicians have to be the center point, the epicenter of the startup ecosystem. So that's one of the reasons why I'm here today with you. With this audience where we have doctors who are going to be doctors in future, they need to step up and be a part of this ecosystem. Otherwise, most of these startups will not see the day of the light. Now, if this is true, why there was a notion that the funding which is no more available for them? So I wanted to highlight some of the facts which is alarming in some form, that there has been an unprecedented funding available for the right startups today in the Asia, in India. I'm not talking about global, we're just talking very specifically locally. That is going into the healthcare place. 1,900 startups globally has come in Q3 alone in the last quarter. These healthcare startups are record-breaking number, up from 15% from previous year in the last quarters. The number of startups have gone tremendously high, and 38% of them are from Asia. Asia, for the first time ever, is driving the innovation in healthcare space, and India is in the center position of that place. We have seen that in Q3 2021, which is the most recent data, the highest deal share ever achieved by the region is in Asia, which is people in the room and the people who are listening to this webcast. And another part which we have noted from here is 54% of these are in early stage deals, meaning those are going at a seed stage. So we had a major blow in 2020 and the last 3 years where the early stage ideas, meaning the ideas which seeking some seed fund to translate into a company, was never getting funded. But that has dramatically came back in 2021, and we are expecting this to be growing much faster in the coming few years. Number of unicorns, close to 91 unicorns have come in the healthcare in last 10 years, and just 10 added in Q3. That means number of unicorns. A unicorn is a startup which is $1 billion in valuation. And this is coming up super fast than we ever thought before. And the last one, I do want to bring it to the table because I do want to spend time on the money part of it. Because 75 mega rounds have happened in healthcare, which is 100 million plus kind of investments in the startups. Now, when we started looking at the specific areas in which these investments are going in, the digital health startups have already raised 27% more funding than in 2020. That means they're going unprecedentedly higher. In 2021 alone, they have surpassed what they have done in 2020. That means they're growing at a much faster rate than anybody else. This is the best time for doctors to step up and be a part of the healthcare ecosystem. The digital health funding in Asia alone is about $1 billion, which is 907 million. And if you can see, it is growing much higher. Globally, about $40 billion has been spent in Q3 in YTD 2021 for healthcare startups. So there is no dearth of money for any healthcare startup that wants to bring it to the table. And just to bring the information closer to home, in Asia deal share has increased all-time high with almost 38% in 2021. And that has increased, seeing some of the biggest investment happening in India alone. So we have two biggest investment in the form of Lenskart and Digit that has raised $1 billion valuation numbers. So this means that the money is not just far-fetched in green Silicon Valleys, but we are talking about money happening in India in our own homegrown space. The last point which I want to bring it to home is the topic on the early stage. Now, the reason why I keep emphasizing on early stage is we have doctors in this room, we have to be doctors. We would like to send this message that if you guys have an ideas and you would like to work, this is the best time to come into the ecosystem because early stage deal share is bouncing back. It's a multi-year low that we have seen in the last 4 years is now gone up, taken 50%, 54% of the money that is spent in healthcare is in the early stage, which is very big money and a big news and a good news for all the doctors who wants to be part of this ecosystem. Now, let's look at what's happening in India. India, this is my last slide, and we're going to go and have a Q&A on this. We have seen that the amount of entrepreneurship and startup that's been grooming in the last 4 years have seen a lot of fund coming into different types of startups that's happening. Look at these numbers. Health tech is the second biggest focus area for investments today, and it is growing at a CAGR of more than 15% quarter by quarter. That means in healthcare in India alone, we are talking about a market size of $160 billion, which was in 2017, has now reached to $372 billion by 2022, which is just knocking the door now. So our market share has become the largest sector in terms of revenue and employment and industry, and growing at a very rapid pace. I'll stop here, and then we may take the questions and make a more interactive session, please.
Thank you, Mohammed Zafar. It was a wonderful presentation. I'm sure there will be a lot of questions. Before I take some questions, I just wanted your perspective on you deliberated on long-term conditions, how does that impact? What is your perspective on long-term care? Because we do see a lot of elderly people and, with chronic conditions, multi-system diseases. So I just wanted your view on that.
Very good question. Now, long-term, as I mentioned earlier, the complexity is increasing in the way that things are going as we move forward. It's not just because of chronic diseases, but also because of various demographic factors. The three things that I'm seeing in this space. Number one is an active aging part. There's as a major amount of preventive startup that could come in to create an environment and ecosystem to avoid any kind of chronic hospitalization or healthcare services. Second, the post-care, usually when somebody go from a stroke or an heart surgery or a major surgery, the post-care services is now being digitized, and it is handled in much more efficient way through the startups that are addressing this problem via the digital or handheld devices. And third, the monitoring system has dramatically changed. The use of IoT, Internet of Things, which is devices talking to each other. A person sitting in home can be easily monitored by clinicians and the physicians and experts across the globe, so that we don't have a scenario that we have to rush to the hospital and create additional pressure on the hospital care system. So this is how the trends is happening as I see in long-term care.
I will also like to add something to your observation, because you have said that now the expanding segment is the mental health care, and I will add to it that it is also the mental health preventive promotive health care, because going by the economic principle of maximizing the return on whatever you spend, with a lot of out-of-pocket expense available with the younger population, and they are tech savvy also in the digital space. The amount of money they are ready to spend to gain the health capital in that segment is increasing. That is the right area to work on. That is why companies like Apple and all have come with all those gadgets and devices with which you can monitor your health or your blood pressure and other things. I think that is a very interesting part. I think we can now make it open for questions. Any questions coming from online? Anybody in the audience? Please come forward for a comment or a question.
Dr. Dilip Kamath, I remember, had mentioned about, you were working in a company in Chennai on the ICU care. Can you just comment on that? I think there are a lot of students here may benefit, I think. I just take a quick comment from one of our faculty members.
Hello. So yeah, ICU at home is one very interesting concept. I think with COVID also, 14 did a lot of work, and there were other home healthcare companies also which were working in that space. I was a part of one of them. We were also managing about 100 patients at home, and technology, we see it as an enabler. At least I see it as an enabler. It cannot be the whole and soul of running the entire show. Sometimes because of a lot of chatter around the technology, the human touch gets forgotten, right? Ultimately, hospital or healthcare is all about the human touch. So technology can be an enabler. Yes, it can make the accessibility to care more easy, but it cannot be seen as the panacea of care. That's a personal opinion.
Thank you for that personal opinion.
Any other questions? Anything from the chat? Nothing? So I must say it was really very nice talk, and I found a lot of, in fact, mental health, one of the major reasons I think is that resilience on the whole is, on the decline. So, that also impacts actually probably, like when we look back to our young days in, 70s, I would remember that if, there would be a power cut for 6 hours, and in, May, June, and I remember I used to spend holidays in Ambala Kant. My grandfather used there. So you would manage. But today, look at the children today, how they will handle. I think all those things are, playing up, and this is like they say 1 in 4, like
that's true.
Your view on this?
Now, mental health is causing, because this is an urban disease that we have created ourselves. It is it's something which has a side effect of our new way of working in a 24/7 environment. In the past, when we used to work, it was a 9 to 5 job. When we go office, we work. When you come home, we sleep. We don't talk about or think about office. Today, the expectation from the junior-most person in the company to the senior-most person is that you're carrying the work home. You're basically taking that to the society, and every single incident that you carry from office, from work to your personal life, it triggers multiple scenarios which cascades into different social issues. And that has been recognized today. And yeah, you're right. The mental wellness was not a center point up until last 10 years. Today, I think it's purely a business case, I would say that, because most of these organizations who employ hundreds and thousands of employees, if they're not productive enough, if the mental health is not good, they're going to be at loss. So, and hence they are coming forward to be the payers of this mental wellness. And as a result, when investor puts money in any particular space, it's an indication that there is a demand for that. Because usually the money guys are quite, I would say, diligent in the way they follow the causes.
Yes, I think for all the students and all those who are the budding entrepreneur, the take-home message, what I gather from the Zafar is that the failure rate being maybe 99.9%, only 0.1% he says are actually making money. And the healthcare space, the failure happens because of lack of identification of the real need of the customer.
Absolutely.
So you start backward, start identifying the real need of the customer, as he says, and then because then the doctor or the clinician has to be inbuilt. And the blessing with you guys are that you are MHAs, you're budding MHAs, you are most of are of clinical background. So 2-in-1 model is already there. So you are the best material for a better success than the other startups, I will say. And then with the 38% of now the startups and innovations coming in the Asian market, the time has come for you now, and please start making up your ideas, make them customer focused. They should fulfill some need of the customer. It should not be the need of the developer. That is the message. I think. Thank you. Thank you, sir, for elaborate. Dr. Jagtar, you want to say something?
Yeah.
Okay.
Could I, with permission of the
Yes.
chair,
Yes, sir.
I'd like to, compliment Zafar for a very beautiful, presentation and putting it so nicely and succinctly, in the time that he had with him. I know there is much more that he can talk about, but what I would like, Zafar, for you to say at this stage is, what are the kind of steps that, anybody who's trying to, venture into this area, what is step 1, 2, 3, that they could take so that it helps them to sort of align their, thought processes and efforts in that direction. Though the two sets of figures that you have, presented, one are very encouraging with the kind of potential which is there in this field. And second is the rate of, sort of failure which is there. So, of course, there are unicorns, but I believe there's another term which is called soonicorns. Billions. So, there may be people may not be, sort of, aiming at unicorns right at the beginning, but soonicorns, yes. So how soon can they start and how do they should start?
Very good. Thank you for that. Let me spend a minute on that, and then we can wrap up the conversation. See, physicians has to take this task of identifying the right problem, which is a bigger problem, not that's something which is solved for a smaller set of demography. So the first step is to identify the problem that you are trying to solve. Has to be super clear, impactful for a larger set of demography than a smaller set. That's number one. And it is very easy for physicians because they are the one who are working with patients 24/7. They see issues, but they ignore it with the focus on moving on to the next patient. I think while they are working in their daily life, they could identify a decent problem that can solve across the globe. That's one, a scalable problem. Second, if they have an idea, I think the best thing for them to do is work with someone who can convert their idea into some form of a business model, right? And this is done by accelerators, people like us. Whitehall Hub is one such company where we bring the idea to a business case, which follows with some form of a seed money. And there are a number of institutions out there where you can pitch your ideas for getting a seed fund. So I think we should do that. That's the second step. So once you have received some initial seed fund, which is usually enough for you to experiment and create a prototype or test the market or get some form of initial sensing, you should then work on with professional organizations. Again, there are different forms of investing that happens. It's angel fund, friends and family. You can go to the angel rounds and then subsequently the serious rounds. But the most important thing is you have to first generate enough traction before going to the third step of raising enough money. Okay? So number one, you have your idea. You know the idea best because the idea is basically solving a problem. And the problem solution should be for the larger audience, not to a small set of it. Second, you can get a seed money to get an idea into testing model. And then the test fails, and the market says this service is not required, or people are not buying your product or not buying your service. Stop there. Don't waste your time, because what happens is after that, usually people take it to personal stage. It becomes their baby, and they take it to so close, they sacrifice everything. First, they burn everything what they have. Second, they burn everything around them. And then they continue to put time and effort on things which the market is saying, no, it's not required. So stop it and then look for other ideas, other problems to solve. If your problem is testing in the second stage, you get a better response from the market. Then you go to the serious money, and there's a lot more money available for the right idea.
Thank you very much. That was great. I think for the younger audiences, it will be great for, especially for even the physicians who are, looking at, venturing into this area. Venturing, I will put it in inverted commas. So great. So thank you. Thank you very much.
Thank you.
Thanks, Ashish and Marwa. I have finished. Thank you very much.
Thanks, Dr. Muhammad Zafar, for presenting such a wonderful, idea about starting an enterprising, company. Now over to the organizer for closing.
Thank you, sir. On behalf of SASH-2021, we would like to present a memento as a token of gratitude to our honorable speaker, Mr. Mohammad Zafar Ali.
Thank you. I accept.
Now, may I request Dr. Paramhans Mishra to present memento to our chairs, Colonel Dr. Vishal Marwa and Dr. Ashish Gupta.
Move on to panel discussion. It will be a privilege for me to invite Dr. Ajay Bakshi, co-founder and CEO, Neurance AI Technologies, as the speaker of the panel discussion. Dr. Ajay Bakshi is an experienced healthcare professional and has played diverse roles as practicing neurosurgeon, stem cell scientist, etc. over the last 2 decades. He has abundant expertise in healthcare with strong leadership skills and passion for innovation. Dr. Bakshi is deeply passionate about using technology to improve healthcare delivery models. Let's hear from him on technology and impact on healthcare delivery. We welcome you, sir. Now, may I invite the panel members, Dr. Colonel Surekha Kashyap, Brigadier Dr. Ajoy Menon, Dr. Anil Gupta, Medical Superintendent, SGPGI, Chandigarh, to chair the session. The session will be moderated by Dr. Pradeep Srivastava.
Good afternoon, everyone.
Good afternoon, sir.
Good afternoon.
Welcome,
Good
Dr.
afternoon,
Ajay
Dr.
Bakshi.
Bakshi.
Good afternoon. Thank you for inviting me.
Good afternoon, Dr. Menon.
Good afternoon, sir. Nice meeting you, sir, online.
Hi, how are you? How we can plan is, Dr. Bakshi will request him to speak on the topic, that is technology and impact on the healthcare delivery. Robotic, MICS, ROSA, Cyber, Knife, and Tomo, etc. Thereafter, we'll request all the panelists to speak for about 5 minutes, and then we'll open the whole session for discussion. Fine?
I think so. Yes, sir. Sounds good.
Thank you.
So we'll start with Dr. Bakshi, who's a neurosurgeon, I suppose. And for last 2 decades, he has been working as a neurosurgeon and an innovator in a stem cell. So he's great experience. What I've seen, actually, I don't know, but I saw in Escorts about 2 decades ago, when the robotic surgery was performed and a cardiac surgery was being performed. So from there, I think it has come to a long way, and I suppose that journey can be brought out by Dr. Bakshi in a nice manner. Thank you, Dr. Bakshi. Please continue.
Thank you, sir. Thank you for inviting me. I hope I'm audible. Everybody can hear. So, thanks for the kind introduction. I'll just quickly run through my journey in healthcare, which started as a neurosurgeon. I trained as a neurosurgeon from AIIMS. I worked as a neurosurgeon for several years. And then I was a stem cell scientist in the US working on spinal cord injury and, the idea of doing lumbar puncture transplantation, which has now become mainstream, actually. In parallel, I did some business education also, which led me to work with McKinsey & Company, where I was working in the United States, of course, for a long time, but also in Africa on mobile healthcare almost a decade ago. So in fact, yesterday I was talking to a Japanese friend and he was saying, what you were talking about in 2010 is now very relevant, and actually the world has caught up with some of those ideas of mobile healthcare. And since this is a conversation with hospital administrators, I've had the privilege of being a CEO of at least 3 large hospital chains in India. I was with Max Healthcare, then Manipal Hospitals, and then the IHH Parkway system. So I speak to you both as a practitioner of medicine as well as a hospital administrator. And over the last 3 years, I've transitioned into a technology entrepreneurship role, and I've built one company called Buddhimet Technologies that we sold just 6 months ago. And I'm in my second stint. This is a small team that we are working on, which is Neurance AI. In parallel, I've also been fortunate to be involved with the National Health Authority, and I'm advising them on the unified health interface and the various pretty significant innovations that they are undertaking. And I'll talk about some of that as well. But to kick off this very powerful topic, I thought I'll take a big step back, because when I hear questions from people, they conflate technology with computers. And I also hear very often from investors and even technology guys with whom I interact a lot nowadays that doctors don't like technology. And I actually argue against it. I said that's not true at all, because doctors use MRI scans and PET scans and robotic surgery. So they're very familiar with technology. It's the information technology that has a slight problem. But to go through a very quick journey of technology, and being a neuroscientist, I've also studied this from the brain point of view. Humans are the only animals which can use tools to make other tools. So we have this power of abstraction. And actually, if you look around yourself today, you're surrounded by tools that were built by somebody maybe 100 years ago, maybe 1,000 years ago, maybe even 5,000 years ago, right? So, and these tools are designed to solve a certain problem that exists at that point in time. Therefore, the previous speaker's point of do the innovation starting with the problem rather than starting with the technology is a very, very appropriate one, and I strongly support that. But if you go deeper and study the trend of how innovation has happened, in the first few thousand years, it was all about physical stuff. It was about wheels, it was about moving, it was about cutting, it was about building buildings. These are all physical activities. Over a period of time, this transition to what I call electrochemical innovations, which is, of course, fire was the oldest one, but more recent ones are electricity, battery, solar, wind, so many other things, because without energy, none of your machines are going to work. So that becomes a very important part. And more recently, in the last 15, 20 years, although the computer revolution started many decades before that, but since the advent of the personal computer in the late 80s, the information technology has become more available to lay people who are not technologists. And of course, the smartphone has taken this to a different level altogether. So this is a broad evolution. And it is also relevant to how doctors deal with patients and how hospital administrators deal with technology. And I'll talk about that. I'll shift gears now from a review of technology to what does it mean in healthcare. So I think of technology in healthcare in two different dimensions. There is technology designed to improve the delivery of healthcare, into which I'll classify all of diagnostics, all of therapeutics. But then there is also technology designed for improving the management of healthcare, which is not actually doing patient care, which is probably a lot of what this audience is involved with. How do we manage a group of doctors and a group of healthcare facilities to be able to deliver what they deliver in a faster, cheaper, better manner? Again, before talking about the future, I always find it useful to take a quick look back because we are standing on the shoulders of giants. And I think what's on this slide will be very familiar with pretty much everybody in the audience, but still 2 points I want to make is that the stethoscope was invented in the 19th century and doctors still use it, right? The X-ray was invented in 1895 and today's X-ray tube technology is essentially unchanged from that. So there are very few industries where 100-year-old technology is still in the front line. Especially, there is one industry, which is education, where the blackboard is still in the front line, which was probably invented a few thousand years ago. And a chalk was also invented a few thousand years ago. But other than that, most other industries evolve and adopt. And for some reason, healthcare has hung on to these relics, which are probably very little useful today other than as symbols, at least the stethoscope and at least a few other things that are listed on this page. Then, of course, ECG happened, cardiac catheterization happened in 1929, which is a bit surprising because it's very early. You have the entire gamut of lab tests starting to come to the mainstream by the 1950s. And of course, then radiology has been the mainstream of diagnostics, starting with ultrasound, going on to CT scan, MRI scan, and PET scan. So I think this journey is a good one to acknowledge, because we'll talk about what's going to happen in the future as well. The therapeutics journey is also started of course, this goes back to thousands of years, but the modern medicine therapeutics really started somewhere in the 1900s when adrenaline was the first mass marketed drug by a company called, I think it was a company which doesn't exist anymore. Then there were barbiturates, insulin, BCG. So again, I won't go into details, but there's one interesting trend that comes out of this. A lot of innovation happened between the 20s and the 60s. New classes of medications were discovered. Vaccines is a whole class in itself. Antihypertensive is a whole class in itself. Chemotherapy is a whole class in itself. These came up in the 50s and the 60s. And thereafter, there has been a plateauing of innovation, and we have more follow-on drugs, or we have drugs like erectile dysfunction drugs, which are multi-billion-dollar drugs, but they solve a problem which didn't even exist. I actually went back to my Harrison's when I was a medical student in 1980s edition. It is lying here, and there is probably one line on erectile dysfunction in Harrison's, but it's one of the largest selling drugs because that's the way pharmaceutical works. Shifting gears to the therapeutic side of the story, again, this is familiar to a lot of people, but still it's worth pointing out that a lot of innovation happened in the 40s and the 50s. Hip implants, renal transplantation, carotid endarterectomy. These are game-changing ideas, and these are game-changing techniques which started in one place. So, for example, the first heart transplant was done in South Africa by Dr. Christian Bernard, but over the next few decades, they have now become mainstream. I remember in the 1980s when I was just starting medical school, there were only probably less than 5 centers in India which could do bypass surgery. And lots of people used to go to Houston to Dr. Denton Cooley to get their CABGs done. And today, I think CABG is done in pretty much every town in India and with very good success rates. So I think we also have something to be happy about. But since this is a talk on innovation and technology, the point I want to make here is, just like in pharmaceuticals, even in surgery, a lot of innovation has happened through the 70s, and then there is a distinct plateauing off, right? Now, why is this happening? A lot of this is because the low-hanging fruits are already captured. The biology, the pharmacology, the biochemistry, the pathophysiology of disease offered certain targets, both for pharmaceutical as well as for surgical interventions. Those targets were well captured by the doctor entrepreneurs, and pretty much all of these innovations were led by doctors. So I think that point on innovation needing doctors is also a very valid one. The previous speaker was making that point. But this is not all doom and gloom. We do see another wave of innovation coming on in the next 20 years. Actually, this is already here. This wave is here. So just to give you a couple of data points, we have been hearing about genomics from 2003 when the first human genome was sequenced. But the cost of gene sequencing, the full DNA, has come down from $3 billion, which was the cost for the first human gene sequencing, to less than $200 now, and within a couple of days. So I think that's opening a new range of possibilities in pharma and drug discovery. Similarly, again, going back to my medical school, it was very mystifying how a DNA sequence becomes a 3-dimensional structure. Yes, we understood mRNAs and we understood ribosomes and all the things that they do, but it was computationally impossible to predict what will be the 3D structure of a protein if you were given the DNA sequence. Google's company called DeepMind has just solved this protein 3D structure prediction problem given a DNA sequence with more than 92% accuracy. And not only have they solved it, they have open sourced their solution. So anybody in this audience, if you have a idea around proteomics and protein modeling, you can go to the DeepMind OpenAI system and feed in a DNA sequence, and it will give you a very highly accurate prediction of what the 3D structure would look like. Why is that important? Because then you can use a 3D structure to do modeling of whether that the protein will do what it was supposed to do. In the traditional discovery method, that used to take years and years of experimentation, and now that may get compressed to a few days or weeks of computational horsepower. So I think this is a very big revolution that is coming in pharmaceuticals. On the right-hand side of the chart, there is a different kind of revolution. So this is not now less led by doctors and more led by engineers, both electrochemical and robotics engineers as well as electronics engineers. And they are trying to come up with a new range of implants and augmentation devices, which today are somewhat in a regulatory no man's land, because the way the regulators work is that it has to be solving a medical problem. But if you have something like a brain-computer interface in a 60-year-old man who just wants to, prevent Alzheimer's, I don't think the regulator is going to approve that today. So I think there is some regulatory innovation also going to be required before the surgical advances come to the forefront. Now, in between all this is a new class of solution which is appearing, which was not there before. And this is called software as a medical device. And in fact, in my company, we have done a lot of research. There is just a month ago, the US FDA put out a list of all approved SAMDs. And SAMD is basically just a piece of software. It does not have a monitor or a device attached to it, but it either plays a role in diagnosis or in treatment. We heard about mental health. In fact, neuroscience is the third most common SAMD that has been approved by the FDA. The first most common is radiology, and the second most common is cardiology. And then this is growing exponentially. And there is a huge range of excitement in how software as a medical device will transform modern healthcare delivery. And then, of course, digital therapeutics is very powerful, again, very early. So if there are doctors in the audience who are keen on exploring this, I will highly encourage you to put a doctor's hat on and do a handshake with a technology collaborator who can then help you convert your doctor's insights into a solution that can go to the market. But since this is a conference for hospital administrators, these are the three questions that every administrator must ask when you are sitting on a chair where you have to make a decision. Is this safe? Is this clinically effective? Is this cost effective? Now, this is, of course, well known to you. But the point I want to make with this slide is that the first two are, for most part, taken care of by the regulators, especially in the traditional systems. And even in SAMDs and digital therapeutics, the regulators are pretty much on the ball, and they will make sure that before this is commercially available, the solution is safe, proven safe, database safe, and is clinically effective. The area where hospital administrators are challenged is this cost effective? And I'll give you my own personal experience. I was running a large hospital chain out of Bangalore. The Da Vinci robot was running out of steam. It was going to break down. And of course, the surgeons wanted a new one. So I asked for an ROI analysis that we bought this 6 years ago. And actually the ROI over 6 years was minus 7%. So theoretically, we should not have bought another one. But guess what? We still went ahead and ordered a $1.5 million brand new spanking Da Vinci robot. Not because of economic reasons, economic reasons, but not because of direct Excel-driven economics, but because of the fact that great surgeons will only work with you if they have these facilities. Those surgeons will also want to attract patients who want to come to a cutting-edge center. So India has that competitive dynamics in the market, and some of that shows up in our decision-making as hospital administrators. So it's a sort of subjective area, and it requires a lot of deliberation and judgment and wisdom to really take a decision on how are you going to pay for this and how are your patients and doctors going to pay for this. Now, shifting gears, we talked about technologies for healthcare delivery. I just have a couple of more slides. I want to talk about how technologies for managing healthcare have evolved. It's very interesting to me, and I did not know this. that Florence Nightingale, who is generally known as the most empathetic founder of modern nursing, and I'll show here, she was actually a very strong champion of importance of statistical measurement for determining the success rate of given intervention and pushed for administrative reforms at hospitals. So I heard a comment in the previous talk, and that comment comes very often, that don't forget the human touch. Technology is not a replacement for the human touch. So for me, Florence Nightingale actually embodies that it is not either or. You need both. Just human touch alone without sound technological innovation is not enough. And of course, just having technology and saying that the human is not required is also not enough. In fact, I met Dr. Eric Topol, who's written 3 books on this interface of technology and healthcare. And he has argued that by 2025, a lot of decision making in clinical medicine will be augmented by AI. But that does not mean that the role of doctor will disappear. In fact, his argument is that doctor will regain that empathy, that counseling, that going deep into the patient psychology and helping the patient make the right choices, rather than struggling with what is the right decision to make. So I think this confluence of empathy and technology is very important, and Florence Nightingale shows that to us. The other huge innovation in hospital administration was done by this gentleman called Semmelweis, who, again, very famous story. You have heard of at least one part of the story, that he discovered hand disinfection as a very important contributor to reducing mortality. Okay, but the fact is that he was not only ostracized by the medical community because the germ theory had not yet been formed. So doctors thought that, who are you to tell us to wash our hands? We are very clean in our own way. And he was put in a mental asylum. He was beaten up, and actually he died of gangrene as a result of those beatings that he received. But his contribution to modern healthcare can never be forgotten. That's why I thought it's important to put him on this page, that this idea of transmission of infection through hands is something that has saved millions of lives. So I want to thank Semmelweis for his contribution. And the third healthcare innovation that has been, of course, we have fast forwarded into the current time now. There's lots in between. I don't have time to go into all the details, but electronic medical records have been not only around for a few decades, but they have received a lot of attention as well as investment in adoption via hospitals. And I have seen this myself in all my hospital administration jobs, that yes, EMRs do play an important role, but as I think of health systems thinking and doing some of that in collaboration with the National Health Authority, we are seeing that the US health system is now in what one of my friends in a large investment firm in California described as interoperability hell. There is no way one hospital data can be shared with another hospital data, because there are these large EMR systems which do not enable or facilitate interoperability. And as a patient, in fact, yesterday I was talking to somebody in Japan. They were saying that even in Japan, if the data is in 3 hospitals, they cannot get it together. So I think we in India have an opportunity to overcome the limitations of electronic health records, like electronic medical records, which is what the Unified Health Interface is trying to do through the National Health Authority, where it will not be an EHR, it will be a personal health record, owned and controlled by the citizen. No ability for anybody to look into it other than those doctors and selected people to whom the citizen has given consent. We have proven this model works in Unified Payments Interface, where today we can go and buy a banana from a vendor for 20 rupees. And in fact, he prefers not to take cash. He says, "Sab UPI se kar dijiye, it will be easier." So I think there is a lot of innovation India is doing, and we'll see some exciting times ahead of this. So going back to my framework of is it safe, is it effective? I think the fundamental goal of the hospital administrator is to create that environment where patients are treated in the most efficient and cost-effective way possible. So I think I'm just in my last couple of slides, and I've talked a lot about the past, but I want to leave you with some exciting ideas that are emerging and opportunities for the model hospital administrator. So pretty much most modern large hospitals today have this sort of an IT architecture. They'll have billing systems. Some of them will even have EMRs, which will have clinical information, lab information, radiology, Some of the more commercially oriented ones will have CRM, customer relationship management, even apps. Maybe sometimes every department will have its apps. The challenge for this is it causes fragmentation and it creates a lot of data, but that does not create insights. So what we have been doing at Neurance, and since I was a doctor as well as a hospital administrator, therefore my startup company is working on how do you take all of that jungle of data on the left hand side and convert it into actionable insights without having to do another very large IT implementation. And thankfully, the artificial intelligence, natural language processing technology has now reached a stage where you don't need to do large IT implementations anymore. You can take the data from these existing systems and do some of these things that are written here, intelligent data extraction. You extract out the clinical entities and leave behind the non-relevant entities. So you extract out what are the procedures, what are the conditions, what are the labs, what are the medications, etc., etc. Then you codify them to standard terminologies. SNOMED is just one of them. It could be ICD, it could be a whole bunch of others. And finally, the most important part is you make a data model that is anchored on the patient and doctor and not on the transactions. If you see the billing system, it will tell you what were the transactions that happened on, say, the 1st of August of 2021. But it will not, if suppose you want to say, what has been Ajay Bakshi's journey through this hospital system, it is almost impossible for most hospital systems to order that. I have myself run large hospital networks. Every hospital has a slight modification of the IT system that is working there and they don't talk to each other. Once I asked, what are the most cost-effective knee replacements? Which hospital does the most cost-effective knee replacement in our system? And I could not get the answer because one hospital wrote it as TKR, another one wrote it as arthroplasty. And the IT guy doesn't know that the TKR is the same as knee arthroplasty, which is, by the way, the same as total knee replacement. So this standardization is very important. And that leads to the answering those three questions that I talked about. Is it safe? Is it efficacious? Is it cost effective? And just FYI, we have started a project with Tata Memorial Hospitals with the women's cancer. And we are using this methodology to build a research accelerator because they are very research focused. And it seems that because of this, what's happening here, it takes their researchers months to build a cohort. And therefore, we are using AI to help them build this data model, which they will then use to do in a few hours or days what will now otherwise take months. So I think these ideas are now here and now in India, done by Indian innovators. So you should definitely explore this. But even more futuristic, and this is my last slide, there are even more exciting ideas. And the one that I am personally most excited about, because I've talked to hundreds, maybe even thousands of doctors, is that doctors are drowning in data. Doctors are saying, boss, this patient comes into my OPD with 30 pages of paper. How am I supposed to see? I'm a liver surgeon. I want to know what is relevant to me. I can't sift through this paper. So there is this new idea that we are building at Neurance. Actually, this has not been done anywhere in the world. That can, just the way Google Maps enables geography to be controlled and used to be navigated, can AI-driven tools build clinical maps that doctors can use to navigate their patients' data? So I think this is in the pipeline. This is going to be launched by January of this coming in a few weeks' time, and you will see a lot of excitement in this. Beyond that, I have met companies which are working on, in fact, just yesterday, there was a company which went live, which listed on NASDAQ. It's called Augmedix. They have a real-time voice-based interaction where a doctor can be taking a round and dictating his or her notes in the ICU. Now, of course, voice recognition has been around for a long time, but this is a version 3.0 of the same because it is real time, it is through a handheld phone, and it is extremely accurate in what it does and doesn't need a lot of training. You also have, I met another company in New York which does natural language generation. Now, what that means is you have the same patient data and you can create a summary for the patient's family. You can create a slightly different summary for the doctors who will read the discharge summary, and a slightly different one for the caregivers, the physiotherapists and the audiologists. It's the same raw data. So natural language generation is the ability to create a human language. And you are aware that GPT-3 and some of these natural language models can now write books and write poems and even compose music, which is indistinguishable from what human beings do. The concept of digital twins and quantified self was spoken about earlier. That's very hot right now. It's going to take another few years before enough people have enough data under their own control so that they can become avatars and move into these the virtual worlds that are being talked about. None of these exist right now other than in the gaming industry. The gaming industry has done a phenomenal job of building these out. If any one of you young doctors plays Firefly or some of these role-playing games, I would encourage you to think about how can they be applied to medicine? How can a group of cancer patients who are actually on chemotherapy have their avatars floating around in these metaverses where they're talking to each other? Maybe they're going to a temple, maybe they're listening to a puja, maybe they're taking a walk in a park. So there are these new ideas that healthcare people have to come up with, which the gaming guys are not going to come up with, but the technologies for which have already been built out. So I think, Dr. Srivastava, I've spoken enough. I'll pause here and I'll just say thank you to everybody. I'm on LinkedIn, and if anybody wants to bounce their ideas off me, because I've seen Indian healthcare evolve through various different lenses, I'll be happy to help you, think through what you are thinking. So I'll pause here and over to you, sir.
Thank you very much, sir. Now I would like to invite the panelists for discussion.
Yeah, thank you, Dr. Bakshi. It was really enlightening, and you have covered it very nicely, the clinical aspect and the management aspect. Thank you very much for that. Now I will request Professor A.K. Gupta, who has been our teacher also. Sir, pranam, sir. And may I request you, sir, to enlighten us about the management technology which is progressing in hospitals, and how do we cope up with the newer robotic technology, and how do we mix them with our management system, which was talked about by Dr. Bakshi, sir?
Voice. You're on mute. We can't hear you. Sir, somebody has muted you.
Very good afternoon to all of you. Many of you are very closely known to me and associated with me. So first of all, let me thank Dr. Ajay Bakshi. Wonderful talk. But then we, being the core hospital administrator, you very correctly said technology for managing healthcare. So I will talk what we at PGI Chandigarh has done. And for those who don't know, let me share you, I am the CEO of the PGI hospital for the last 26 years. I'm also Dean Research, and will be hanging my shoes this month. But what innovations we have done? Absolutely true that technology for managing healthcare has to be developed. No, there are two things. It is not that we have to develop the technology on its own, like the MRI, ECR, blah, blah, blah. But second is, you can use newer use of the existing technology. And at PGI, we have done a couple of innovations which have won appreciation, and I will share you some of the things. Average length of stay. The average length of stay at PGI was a little high, and there was plenty of the patients who were waitlisted. The demand for the hospital bed was tremendous. How to reduce it? It is to reduce the average length of stay without compromising the quality of the care. Because as a hospital administrator, our focus is to increase the productivity and to improve the quality, which I say P&Q formula, productivity and the quality. So bed was a very big issue. And lo and behold, what we did is, when I used the concept of embedded software. That means the concept I picked up was from the credit cards or the digital booking of the railway tickets, air tickets, or you go and use your credit card on the merchandise the moment you spend the money, before the merchandise or the airline or the railways collect the money, you get the message, hey, Mr. say Pradeep Srivastava, Brigadier Producer, you have incurred an expense of 1,100,000 rupees for a ticket which is going from Delhi to Bombay and it is being going to the SpiceJet. You get the SMS message before even the SpiceJet collects the amount. So what we did is, okay, we have got a hospital information system. Let's put a embedded technology, little software, that when the patient has stayed in the hospital for 7 days, on the 8th day at 8 a.m., it sends a message to the treating doctor, hey, you have this patient ABC, admitted in ward 123, by CR number such and such, and he has stayed for 7 days, which is the average length of stay. And then we stop, because our aim is not to guide the clinician on clinical treatment, just a hint. And on second week again, second reminder, third week, third reminder, and the fourth week to the HOB. And I got the approval from the hospital management board. Let me share with you the average length of stay in 2014 when we started was nearly 9. And by 2020, it was touching 6.9. The result was in the 2020, there were around 20,000 more admissions against the same infrastructure, against the same number of beds. So that is what is embedded technology. So in the very beginning, I said two things: increasing the productivity and then improving the quality is the aim. And you don't have to invent a new technology. Find newer ways of existing technology. Another thing I can give you, another example of similar embedded technology. There are others also. The time constraint will just cornea donation. Everybody knows that there are around 11 lakh Indians who are blind because of cornea blindness. Cornea ulcer. So what we thought, when the patient dies, the moment the staff nurse or the resident enters the death of the patient, the hospital information system, we embedded a little software that it sends a SMS to my eye counselor and the junior resident ophthalmology on duty. Hey, Mr. X, admitted in ward 123 on bed number X, has died. The family is trying to complete the formalities, accounting, accounts clearing, waiting for the discharge, and my eye counselor and the junior resident will approach. And the answer is, within half an hour they will be there. They will counsel the family, are they willing to give the corneas? And we assure them they will not disfigure the face. Let me share with you, when I joined the PGI in 1996, the average length of cornea donation was around 60 per annum. And in 2014, when we started it, it started with the 500 corneas a year. It went up to 900 corneas in a year. And in the 26 years I am here, we have collected around 9,000 corneas. And as far as the transplantation rate is concerned, I don't enter into the domain of the ophthalmologist. And it is done out with the team. And there is 80%. So what I want to say is that you can use the existing technology, find innovative ways. There are many innovative ways we have done. And some other thing, PCP and DT. We got a legal notice that we will be prosecuted for sending the report later. So we use the technology that on for 4 continuous days, 2 days before the end of the month and 2 days on 1st and 2nd of the month, we send SMSs and closed user group. Hey, send the report, or you face a memo from the appropriate authority and you will be resolved. And lo and behold, compliance is 100%. And not only this, appropriate authority of the Chandigarh, in its conference with all the appropriate authorities involved in the PCP NDT Act implementation, admitted that is the best in the PCA. So what I want to say repeatedly, that you may not find new technology, but there is every reason for us to find newer use of existing technology. Couple of last 2-3 words I would like to say, though, but there are plenty other innovations we have done. 30 major issues of the hospital management we have found it, and every month we send them the message through closed user group and get the free feedback after every month. And the result is all 30 points, major, pilferase, hospital-acquired infection, all of them have been tremendously checked. I won't say they have been wiped out, tremendously. And I can also say when I joined 26 years back, there I was full of all the problems. Only yesterday I was sharing with my faculty that I have problem with my faculty that you don't give me a single opportunity to have hospital problem, because we use the technology. We use WhatsApp a lot. Not many small groups are made, and we use that, sending the message. It leads to what in the army language we say SAM, surface to air missile. I say speed, accuracy, and memory. That is. So I believe we don't, hospital administrators don't have to find new technology. You just start finding newer uses of the existing technology. There are many more issues I can always there, but a couple of things. High cost. You must say that the nation cannot afford high cost. It has to be confidentially. If the information is generated, confidentiality has to be ensured. User errors has to be checked, and the technology we use should be patient-friendly, beneficial to the institute, without increasing the administrative aspect. But above all, medical, legal, and ethical issues should be addressed very rigorously, so that we, while inventing or finding innovations to find hospital management issues, we should not land into any medical, legal, or ethical issues. With this, I thank all of you to having given me the opportunity to share few of my innovations at PJ. Thank you. Over to you.
Thank you, sir. Thank you very much. So just one question here, sir, before I actually shift to the other panel. You were talking about the embedded technology, sir. So now in this embedded technology, can we have a health card system which can be available like an Aadhaar card to each and every individual, and thereafter it is available with each individual wherever he goes, whichever hospital he goes? This technology, the information can be taken from one hospital to another hospital, which Dr. Bakshi was saying that it is not possible presently because of whatever reasons they are. So can you enlighten us on this, sir?
I personally feel nothing is impossible. Rather, you break the impossible, it must be possible. But then it's a very big field. Authorities need to sit together and find a solution. I can quickly, even Dr. Ajay Bakshi has very rightly said about the man who said that this is a hand washing. I will give you two examples, which one you may be aware. Marconi, when he said if we can send the message through telephone, you can also send the message through wireless. And even his family member said he has gone mad. He got him admitted in the asylum. Another example, so it is possible what you say. Another thing quickly, let's take up Sundar Pichai. People say how the Google Maps have emerged. They say the story goes, objective is not storytelling. Objective is triggering a desire in you to go for the innovation. They say Sundar Pichai was invited with the wife on a dinner party. He was in the office. He asked the wife, kindly go to the family dinner. I will reach the site in the time. Lo and behold, while reaching the place of invitation, he lost the track. He reached the house of the guest, and at very late, he said the party is over and your wife is gone. So the story, how far it is true, I don't know. But then once he reaches the home, his wife doesn't permit him to sit. He said, you have messed up our today's dinner. He returns to the office, and then it struck to him, bloody, I have lost that track. So there will be thousands of people who will be losing the tracks. He called all his officers, hey, come sit. Is there a way out? For 2-3 days, they said there's no way. He continued with this, and lo and behold, Google Map is the way out. So whatever you are saying, it is possible, but the experts need to sit together, flag all the issues, and experts can give the solution. It is absolutely possible. The passion, commitment is the answer. Thank you very much. Over to you.
Thank you, sir. Now I'll switch to another panelist, Brigadier Menon. I just want to add few things which you may like to enlighten us on is the nanotechnology in medicine. That is one thing. Genomics, which was called upon. The pharmacogenetics, which is also was spoken upon. You are the clinician. Can you touch upon these things and how we can manage these things besides the technology which you are going to speak about?
At the outset, let me say that I'm thrilled to see Surekha Kashyap ma'am and Pradeep Srivastava sir, both of you. I mean, you've been my seniors in AFMC, and I couldn't believe it when I said I'm sitting in a panel with you. And it's rather befitting that we're discussing the role of technology and its inextricable link with healthcare. Sitting here in Amrita, which is one of the pioneers, which is the pioneer down south for ROSA, minimally invasive surgery, and so on and so forth. Now, as a cardiac surgeon in the past, I can say that it is definitely possible for us to envisage the role of a clinician with technology in mind. But for that, the rider in this is that one has to know the path one takes. And for this, I'll just go back to the excellent lecture which Dr. Bakshi has given us, because he's rightfully disengaged the mental image of technology with digitalization alone. Technology in the context of medical healthcare involves the rightful use of the ability to clinically be relevant and to kind of jump over the small potholes and arrive at a conclusion which is beneficial to a large number of people. So that is how technology empowers. In the context of genomics, in the context of neurotechnology, the issue is not the use of AI alone. The issue is how relevant it is when it's applied, and how easily how easily will doctors perceive it to be useful in their applications. So in this, I must just tell you a small example. In cardiac surgery, there was a time when people used to actually keep blind jabs when we used to do a pleural tap way back. Surekha ma'am will remember, way back in the 80s, without an ultrasound. An ultrasound came, it revolutionized everything today. And today, an ultrasound is no longer enough. You need a focused ultrasound. You need a better probe. You need the radiologist to tell you exactly where to puncture. So technology, in the relevance of technology is only in as much as the accuracy with which the clinician wants to use it. In the context of medical care, it tends to be subsumed in the larger debate of cost-benefit analysis, and it dilutes the stellar role of the game-changing pathway breakers that technology has had over the decades. So what we're seeing now is a crystallization of many decades of painstaking research, and that is what the lecture highlighted. What we're seeing now is a crystallization of hundreds of years of people working very hard, which we take for granted. So I won't take more of your time, sir. That's all I have to say. Thank you. Over to you, sir.
Thank you very much. And now I will request Dr. Surekha Kashyap. She has been closely with us in AFMC, and she was one of those who has been helping the students to come up to great expectations which was supposed to be brought out, and people have been doing extremely well in their life. Now, may I also request you, besides you are telling about the technology, about the cybersecurity thing in the medical organization besides other things?
Thank you so much, sir. First of all, I would like to start by saying a big thank you to Amrita Institute as well as AHA Noida for giving me this platform, which I share with a lot of happiness and honor with my teachers, my gurus, my seniors, one junior, and Dr. Ajay Bakshi, who represents the most important thing which all administrators must remember. I've always said that it is important for administrators and clinicians to work hand in hand. Otherwise, patient care will not improve. The clinicians cannot get away by giving a second class or a second citizen thought process to the administration, because a good administrative setup will ultimately result in the outcome which the clinician also desires, which is a healthy patient and a happy patient. A happy patient will listen to your discharge advice. There will be less of readmission. All the patient-related outcomes would be better. So that is the reason I would like to start what I'm saying. We'll come to cybersecurity later, because it is a part of how the system, I feel, should organize if we are going to say that we want to use technology for healing, which is the topic of SASH-2021. And that is that since today is Navy Day, so it is apt for me to start by invoking the way a ship sails, So the first thing is that the ship should have a wonderful captain, so leadership. A captain who knows how to lead, to inspire, to get the team together, and who knows what he's doing. But if the ship does not have an engine, it will not sail. So that engine, according to me, is the technology. Technology is not just required to make the ship sail faster. In today's world, technology is required to keep you afloat. If the engine shuts down, nothing happens. But the other part is very close to my heart. I'm very passionate about that as well. And that is ethics, or what is the mission statement of your organization. And that is the rudder or the compass. You start the ship, the engine starts, but you don't know where you are going. You don't have a compass to tell you that you have taken the wrong path and you will get lost at sea. So maybe these two things should go hand in hand, ethics and technology, or the goal and mission of the hospital. If the goal and mission of the hospital is a healthy and happy and satisfied patient, and also happy and satisfied staff who are equally important, then probably the ship will sail properly. So we talk about this, I'm very fond of the Donner-Biddle model. And when we talk about technology, technology can help in all three: input, process, and output. So traditionally, we say that a hospital administrator can have a wonderful impact on inputs by reducing the cost of input, and can have some effect on outcome measures, designing the outcome measures, keeping track of outcome measures. The process is difficult for an administrator because the process is almost completely in our setup in India, at least, completely clinician-driven, clinician-centric. So there is this doctor-patient bond, which is sacrosanct, should remain sacrosanct. But since the doctor-patient interaction is key to the outcome, and it is also the key driver to decide what input should go in, some discussion about the process is mandatory. So for example, in input, if you can use technology to improve your material management. I mean, you can put RFIDs and, when you have unit dose dispensing system to reduce the wastage or shelf life expiry of medical products in your inventory. If you have, like, Armed Forces has this standing inventory of in the pharmacy, which we call medical stores. And by the way, the having of the reserve stock in our medical stores was one of the reasons why the Armed Forces hospitals weathered the first wave of COVID a little better logistically than the others, because we have the system of inventory control, which is very different from just-in-time inventory. We don't do JIP. Then in process, starting from giving an appointment to the patient, to the way consultation takes place, to the speed of the investigations, the procedures, the admission process, the medical record keeping, the billing, the discharge, and even the follow-up. Everywhere technology can be used. And now it has to translate, this is especially for the young doctors and budding hospital administrators in the audience, it has to come on the mobile in the form of an app. I take modules on legal and ethical issues, and we are far behind the world when it comes to legal compliance with simple things and common things like consent. Informed consent is, I think, more absent than present in our process. And one of the ways to get it done without wasting time of the doctors, and all doctors say they don't have time, make an app. Just like in banking sector, unless you click and you read what is the disclaimer and you just say, yes, I have read and understand, till you have that, your appointment for surgery cannot be done. So there is a lot of technology which can come into the process apart from robotic arms and those costly crores worth of equipment which we buy to improve our process. The second thing is that there was this question about the cost effectiveness of or return on investment. That takes us back to the captain of the ship. What is the goal of your organization? So if one of your outcome measures, all the hospitals have two outcome measures: satisfied patient and satisfied staff. That is a no-brainer. Everyone wants a patient who's cured, who does not get readmitted, who's happy, who gives wonderful scores on your patient satisfaction survey, and your staff has to be happy. Otherwise, they'll quit and go somewhere else to greener pastures. But is your third goal or outcome measure cost containment? Unless you have it as an outcome measure, you will not do any kind of effort to evaluate whether a new process technology is required or not. And there is a technology available. It is called health technology assessment. It's a formal body. It is available for us. Unfortunately, it is not very popular because it forces us to quantify people's lives and the quality of their life as QALYs and DALYs. But there is a technology available to give you absolutely, dollar to dollar comparison between a new technology, whether, and I'm not even talking about the capital cost. So it over the years, if you say that, okay, in 1 year, 20 patients will benefit from this, that projection has to be done. And this, again, HTA works only if there is a collaboration between the clinician and a hospital administrator, and for good measure in HTA, a statistician, preferably a biostatistician who's trained in HTA, is co-opted. So today you cannot talk about innovation and technology in an isolation. You cannot say that a clinician will be the best one to do it, or the hospital administrator will be the best one to do it, or an entrepreneur or an engineer can do it. We have to learn to work together so that the brainstorming brings the best and optimal result. Lastly, I feel that any technology in the context of today's topic, which saves the time of patient or staff, which saves money for the patient as well as for the hospital, and which saves errors. Okay, so error prevention has not been talked about much. Again, it is something very close to my heart. Any technology which can prevent harm to the patient is going to be worth it, whatever it costs. It is, I believe, the one exception where the capital cost should not be taken as a deterrent. If any technology comes in which can avoid any kind of adverse event in a hospital or a healthcare setting, whether it is a patient fall or with wrong medication or wrong surgery or wrong identification, it is worth it, whatever it costs. That is all, sir, I had to say about cybersecurity in healthcare. We recently had I think I read the news article where a hospital has been taken hostage and all the patient data and financial data has been hijacked, and the hijacker is asking for millions of dollars in Bitcoin currency. This has already happened in India. It is India I'm talking about, southern India. So we have to be very alert. We have to have, though it will, we live in a world where the hackers will always be a step ahead of us, but it should not lull us into any kind of complacency. The best thing to do is to give the control of the security. There should be multi-level and multi-layered security of patient record and patient data, whether it is clinical data or it is financial data. And the control of patient records must always be with the patient. And in order to improve the cybersecurity, a second layer can be added as a cybersecurity firewall from the hospital side. The second thing is that any software today in 21st century, any kind of software which you are installing becomes very quickly obsolete. So constant review of the goodness of your firewalls, of your protections. And it, again, you cannot say that I will do it every month or every quarter or every year. It has to be an ongoing and constant process, just like a sportsman. They train every day because they have to maintain their muscular strength and their fitness and their swiftness till the day they compete. They cannot say that I will do workout only once a week. So it has to be a constant thing, sir. There are no easy answers as far as cybersecurity is concerned, but we must understand.
I think the feed has got interrupted, sir.
Yeah. We'll proceed further. She was talking about cybersecurity. I will also talk about, may I request Dr. Bakshi to enlighten us. He said he is analyzing the data and navigating the data. There's a huge data which is available from each hospital. We may call it as big data or whatever we may call it as. And we are also doing data mining for our own purposes. With these two things at background, and on the other side, there is a cybersecurity, there's a hacker. How do we relate these two things, and how do we prevent this, and how do we prevent the this leak to happen?
That's a great question, sir. My view is slightly, what should I say, unconventional in this. The fact that hackers are coming after this means that there is a lot of value in this. Of course, they have a very twisted mind and they're doing it for a different reason. But it is true that healthcare data, particularly in the United States, is a very big target for hackers because it has your mother's maiden name, it has your social security number, it has a lot of pieces of information that can be used to then hack your bank accounts and other important sensitive information. So I think that arms race, as Madam was mentioning, it's an arms race. You have to be one step ahead of the hackers, and there is no escaping it. But having said that, and having built systems and having brought in experts who know how to fight that arms race, I would say that hospitals have data. But having worked in AI for the last 5 years now, 70% of work of artificial intelligence is about cleaning the data. So just having data in your EMR system is not equal to having data that is valuable. There is a lot of cleaning, deduplication, filling up of missing values, as well as codification. I talked about standardization. If it is not standardized, then it is not analyzable, and it is as good as very coal or oil sitting deep down in your earth. So in fact, the oil analogy is very similar. You first have to mine the data / oil, then you have to refine it in a refinery, which is what a lot of AI is about. And finally, you need to have an AI engine which creates value. In oil, it is an internal combustion engine which creates value. In machine learning AI, it is the AI engine which creates value. So India is fortunate that it has a lot of data, but I think India is also open for a lot more innovation, which is what we are trying to do. That instead of saying, okay, what is happening in Silicon Valley, can we replicate that in India? The US health system is very different from the Indian health system. And the US regulatory, HIPAA, all other medical legal situation is quite different from India. I actually think India has a lot of opportunity to leapfrog the US in doing some things much better and much stronger for the citizen, rather than the way the Americans have done it. So I think it's a very open field, and I would love to see more innovation happening in this space. I am doing my little bit in this.
Thank you. Thank you very much. Now, discussion is open to everyone. Anyone who wants.
I have a question. Dr. Ajay. Excellent presentation, sir. Enlightened very much. So, now if you see, if you break down our healthcare, we have patients diagnostics and treatment, then you have the administration, you have patient engagement.
You are not very clear. Can you be more
audible? You hear me?
Yeah, now better.
Yeah. Actually, I was telling that, if you break down our healthcare, we have diagnostic and treatment area, then you have patient engagement, then the administrative. So most of the technology application in AI space has been directed to patient care and very less in the administration side. And first thing is there is lack of data in terms of administrative aspects. And other thing is especially when we talk about data quality, like collection and data quality, which is not occurring as required, in terms of machine readable. So the question is how do we ensure data quality? And the second question is now you mentioned you are building a product on neurons, which is related to administration, patient journey. You are trying to map patient journey. So how do we integrate this in our flow, day-to-day working of the administration, And how do we integrate with electronic patient records or HIs? So we have so many innovations which are coming up, but they are in bits and pieces. And we have blockchain, we have quantum computing which is coming up, and they are able to address some of the issues like cybersecurity, all which but they are not in an everyone talks about in bits and pieces. Like some innovation is happening in other part of the country, some innovation are happening in India. So how do we integrate those all things into one piece and start functioning in a better way to solve many of our healthcare problems when it comes to efficiency and cost? So this is my question.
I got your question, Dr. Purushottam. Thank you for your comments. I think we're running out of time, so I'll be very brief. I think the right question to ask, and I've also been on this journey when I was a hospital administrator, then I used to ask, I have all this data, what can I do with it? But actually the real question is the reverse. I have this problem. In order to solve this problem, what data do I need? And how do I go about collecting/cleaning it? I think Mr. Zafar also spoke about that start with the problem, because then a lot of wasted effort goes away. So for example, Tata Memorial gave us a problem that we want to accelerate research. That's it. And for research, we want to have data that we can build cohorts of 20 different variables in a day's time instead of 6 months. So it's a very narrow problem at one point. Instead of saying, like what I used to do when I was in Manipal, that I have so much data, what can marketing do with it? What can clinical quality do with it? I think there it doesn't go forward. So I will highly encourage anybody who is interested in making progress in using data analytics is to flip the problem. What is the pain point that your doctor is facing, or your patient is facing, or you as an administrator are facing? Then ask the question, what data can help you answer, or what analytics can help you solve that pain point? I think you will make much more progress that way. It's a narrower way to do it, but it's a more effective way to do it.
Yeah, thank you very much. I will just add one thing. This standardization is very, very important thing. If the standardization is there, then and the data cleaning which was talked about, these two aspects is there, then probably we'll able to achieve everything.
Absolutely. Absolutely.
Thank you very much, all the panelists. Thank you. Now I hand over back to Amrita Institute.
Now, on behalf of SASH-2021, we would like to present a memento as a token of appreciation to our speaker, Dr. Ajay Bakshi.
Thank you. Thank you so much for inviting me.
Also, we would like to present a memento to our chairs, Colonel Surekha Kashyap, Dr. Anil Gupta, and our moderator, Dr. Pradeep Srivastava.
Thank you. Thank you very much. Thank you.
Now, may I request Dr. Dinesh Nayasar, Chairperson SASH-2021 and Head of Hospital Administration, Amrita Institute of Medical Sciences, to present the memento to Brigadier Dr. Ajay Menon.
And welcome you all to the quiz competition. We had a preliminary round via Google form, and we had approximately 38 responses, and we picked up the top 5 who are going to be with us live for the round 2, that is the final round. So these are the top 5 teams. We have team 1, Ms. Preksha Dadich and Ms. Sania Sharif from JSS Academy of Higher Education and Research. Team 2 is Major Dr. Sanjay Yadav from Armed Forces of Medical College, Pune. Team 3, Dr. Anmol Jain and Dr. Chris Agarwal, King George Medical University. Team 4, Dr. Moindra Haldar from Symbiosis Institute of Health Sciences, SIU, Pune. And Team 5, Mr. Vipul Ingal and Ms. Seema Jocelyn D'Souza from Father Muller College of Allied Health Sciences, Mangalore. Please, all the participants, keep your videos on. We have shared the guidelines to you. So please keep your videos on, all the 5 teams. Know your team order, team 1, 2, 3, 4, and 5. Right? We'll begin our first round, round 1. And this round is of 20 points each. You need to identify the famous personality. If you answer correctly within 10 seconds, you get 20 marks. If you can ask a hint from me after 10 seconds. If you ask a hint, you get, and you answer it correctly, you get 10 marks, not 20. So we'll begin our round 1, and each round we'll move on. We'll start with the next consecutive teams. So round 1, we'll begin with team 1. Round 2, we'll begin with team 2, so on. We have total 5 rounds. So round 1, team 1, you will get 60 seconds to answer. Identify the famous personality. Please unmute yourself. All teams, please unmute yourself.
Yes, ma'am. We were unable to unmute ourselves.
Yeah, fine. So your time starts now. Please identify her.
Nightingale, ma'am. Florence Nightingale.
You don't want any hint?
No, ma'am.
Your answer is wrong. She's Mary Parker Follett. She's also known as Mother of Modern Management. And she defined management as the art of getting things done through people.
Okay.
We'll go to team 2. Please identify the famous personality. You may ask me hint. Your 10 seconds are over. Please unmute yourself. Team 2. Dr. Sanjay Yadav. We can't hear you, Sanjay. Dr. Sanjay Yadav. No, we can't hear you, Dr. Sanjay Yadav. We'll move on to team 3. The next question. Please unmute yourself. Team 3.
Hello. It's Peter Drucker. Hello.
Hello.
Yes.
Are you able to hear us?
Yes, we are able to hear you. Team 3.
Yeah, it's Peter Drucker.
Very good. So you get 20 points. We move on to team 4.
Am I audible?
Team 4.
Am I audible?
You are audible.
Okay.
Ma'am, am I audible, ma'am?
Yeah. Team 4, please.
Ma'am, this is me from Team 4. Ma'am, can I get my hint?
Team 4, okay. He is also known as father of quality management.
Okay. Is it Deming?
Right. So you get. He's William Edward Deming. You get 20 marks. 10 marks. You asked for a hint, so you get 20 points.
Yes.
Oh, sorry, 10 points.
Okay.
Team 5.
Poonawalla.
Huh? Can you repeat?
Poonawalla.
Full name?
Cyrus Poonawalla. Sorry, Adar Poonawalla.
Right. So you get 20 points. Adar Poonawalla. He is the CEO of the world's largest vaccine manufacturing firm by number of doses produced. So you get 20 points. We move on to.
Excuse me, ma'am.
Yes.
Ma'am, I'm from Team 2, ma'am. Am I audible, ma'am?
Yeah, fine. You are audible. Do you want to take this question? You'll get 10 points if you answer correctly.
Yes, ma'am. Wilfredo Pareto, ma'am.
Very good. Excellent. So 10 points because you were not able to tell when you were allotted the time. So you'll get 10 points. Okay.
Yes.
Round 2, we begin with team 2. For each correct answer, you'll get 20 points.
Return of investment
is calculated by using the formula.
Cost of investment by net profit into 100 and net profit by cost of investment into 100. Ma'am, the answer is B. Net profit divided by cost of investment into 100.
Very good. You get 20 points.
Okay.
Moving on to team 3. Hospital bed turnover rate is calculated by using the formula.
Ma'am, where is the question for team 2, ma'am?
Team 3.
You have skipped me, ma'am.
See, don't create confusions. Round 2, the first answer should have been from team 2, but team 1 answered. Okay. So now I'll give you. So this is for team 2. Hospital bed turnover rate is calculated by using the formula.
Ma'am, it is B, ma'am.
B, number of discharges including deaths in a given time period.
Divided by number of beds in the hospital during that time.
Very good. You get 20 points for that. And please don't take references or help from others. We can see you, all of you. Okay. Moving on to next, team 3. Economic order quantity, otherwise known as EOQ, is calculated by using the formula. Square root of twice of multiple demand into cost per order upon annual holding cost per unit, or is it square root of an annual demand into cost per order divided by annual holding cost per unit, or is it twice of annual demand multiplied by cost per order upon annual holding cost per unit whole square, or is it annual demand into cost per order upon annual holding cost per unit square?
I'll go for option A.
Correct. So she gets 20 points. Team? Hello. This is team
Hello.
This is team 4.
Ma'am, then where's the question for team 3?
Ma'am, I think there's a confusion with the, numbers.
Okay, fine. So
But I answered my question. I'm team 4, so I answered
Okay, fine. So we give team 5 20 points. And the next question is for...
But ma'am, I answered...
Yeah, your answer was correct.
But ma'am, I'm team 4, right? I'm Moindra.
Yeah, you're team 4. You will be given points. Team 4, your answer is correct. EOQ is square root of twice of annual demand into cost per order upon annual holding cost per unit. Next, we move on to team 5.
Ma'am, question for team 3.
Okay, so next, this is your question, team 3. Inpatient bed occupancy rate in hospital is calculated by using the formula. Team 3, we can't hear your response.
Answer is A. Total number of inpatient days for a given period divided
Sure.
by available beds into 100.
Sure.
Hello.
20 seconds left.
Yeah, answer is A.
It's C. Total number of inpatient days for a given period multiplied by 100 upon available beds into number of days in the period. It's C. So you get 0 points for this. And next, the last team, team 5, Vipul.
Yes, ma'am.
Yeah. Break-even point is calculated by using the formula.
Ma'am, the answer is D.
No, it's C, fixed cost upon contribution margin. And contribution margin, otherwise you can write it as sales price per unit minus variable cost per unit. So the correct answer is C. So by the end of 2 rounds, we have scores. Raj Lakshmi will tell us the scores.
Team 1, round 1, 0.
The total.
Round 1, team 1, 50.
Unable to hear, ma'am.
2 rounds. Team 1, 20. Team 2, 30. Team 3, 20. Team 4, 30. And team 5, 20.
So we have 2 teams with 30 points each. So they are the leading ones. So next, moving on to the 3rd round. Please listen to me carefully, the sequence. Round 3 begins with team 3, then team 4 has to answer, then team 5, then team 1, and then team 2. Please don't break the sequence. We'll begin round 3 with team 3. The next question will be for team 4. So round 3, first question is for team 3. Identify the false statement about biomedical waste management. Yes, team 3.
It's D.
D.
Please read out the answer.
Hello?
Yes, please read out the answer.
Yeah, the answer is outsourcing is not recommended.
Yes, your answer is right. So that is the false statement. Outsourcing is recommended if treatment facility is located within 75 kilometers of radius from hospital. So you get 20 points for this. So team 3 gets 20 points for this. Next, moving on to the team 4. Again, I repeat, team 4. Identify the false statement regarding the Transplantation of Human Organs and Tissues Act 1994.
And the answer is C. Near relative excludes grandfather, grandmother, grandson, or granddaughter.
Right. This is the correct answer because near relative, the term, it includes grandfather, grandmother, grandson, or granddaughter. So you also get 20 points for your correct answer. Next, moving on to team 5. Identify the false statement regarding the Medical Termination of Pregnancy Act 1971.
MC, go first. MTP cannot be done where any pregnancy occurs as a result of failure of any device or method used by any married woman or her husband for the purpose of limiting the number of children.
You're absolutely right. So you get 20 points for this. It is included, or it is, you can do MTP in such cases because it can cause mental anguish for the pregnant lady and her husband too. Next, moving on to Our next team, team 1. Please unmute team 1. False statement regarding Drugs and Cosmetics Act 1940.
What options here?
Ma'am, some words of the slide are not visible, ma'am.
No, it is visible. We can see.
Which?
Team 1. Preksha, you can see the slide, right?
Yes, ma'am. We are reading, ma'am.
Yeah, fine.
Introduction.
You have 10 seconds left.
Ma'am, we'll go with option C. Yeah, option C, ma'am.
Please read it out.
This Act regulates the manufacture, distribution, and sale of drugs and cosmetic in India and does not regulate their import.
It's right. You get 20 points for that. This Act also regulates their import.
Import, yeah.
Yes, ma'am. Well done. Moving on to team 2. Identify the false statement regarding the National Medical Commission Act 2019.
Ma'am, I will go with the option B, ma'am.
Please read it out.
The Ethics and Medical Registration Board shall maintain a national register containing name, address, all recognized qualifications possessed by licensed medical practitioners.
You feel this is a false statement. Question is identify the false statement. You have 5 seconds left. Sorry, Dr. Sanjay, that is not the right answer. Right answer is D. The central government shall constitute. Here it is mentioned 3 autonomous boards, but actually there are 4 autonomous boards. Apart from the 3 named here, the 4th one is Medical Assessment and Rating Board. So that is a false statement regarding NMC Act 2019. So
Right.
you don't get any points for this. So at the end of 3 rounds, the scores are?
Team 1 has 40 points. Team 2, 30 points. Team 3 are with 40 points. Team 4, again, 50 points. Team 5, 40 points.
So we have team 4 as a leading. Dr. Moindrala Haldar with 50 points.
50 points.
So the remaining teams, please buck up. You have 2 more rounds to go, round 4 and round 5. So round 4, we'll make it interesting by, again, the points are same 20, but if you don't answer within your 60 seconds, you can pass it on to your next team. And the next team will get 10 points. Okay. The next team, again, don't create confusion for that. So we'll round 4, we'll begin with team 4. So if team 4 doesn't answer, team 5 will get the opportunity to answer. Okay. We'll go in the sequence. If team 5 doesn't answer, team 1 gets the chance. Okay. Fine. So round 4, team 4. Which of the following statements about Sentinel event is false?
A, option A.
Right. So, can you please read it out?
Yes, it is any unanticipated event in healthcare setting resulting in the death or serious physical or psychological injury to a patient or patients related to the natural course of the patient's illness.
And can you pinpoint what is the wrong here?
Basically, this is only relating to the patient illness. Sentinel is like a guard. So in case of epidemics or pandemics or anything like that, it's basically about managing epidemics. It's in that concept, sentinel events are taken into consideration.
The correct point here is that what is mentioned on your screen is related to the natural course of patient's illness. It should be unrelated to the natural.
Yeah, not related to the natural
okay,
events.
Fine. So you get 20 points for this. Team 4 gets 20 points. Next, team 5. Which of the following statements is true regarding medical negligence? Is true. Team 5.
Ma'am, we'll go with B. Option B.
Please read out the statement.
Where a patient's death results from error of judgment, criminal liability should be attached to it.
The following statement is true about medical negligence.
Yes, ma'am.
Sorry, it's the wrong answer. Correct answer is A. To fix criminal liability on a doctor, the standard of negligence required to be proved should be as high as can be described as gross negligence. Next, moving on to team 1. Which of the following risk management techniques is correctly written in the table below? So you have 4 options, A, B, C, and D.
Ma'am, down is not, we can't see the D option, ma'am.
D option is both frequency of loss and severity of loss are high, and the appropriate risk management technique is retention. Which of the following is correctly written?
Okay, I think.
High, low, road prevention and retention. I'll tell. Ma'am, it's option B, high, low, loss prevention and retention.
Absolutely right. So you get 20 points for that. The rest 3 options are wrong. Do you want to know what is wrong? So when both are high, you need to avoid it. When both are low, you can retain it. And when the frequency is low and severity is high, you try to get insurance for that. So the correct answer as given by team 1 is right. Next, moving on to team 2. All of the following statements about systems approach of management are true except.
Ma'am, I will go with the option C.
Please read it out.
The output of a system is never greater than the combined output of its parts.
Can you find out what is wrong in this? It's right. You're right.
It should be. It should be a. It can be greater, ma'am.
Right.
than
It
the
is
combined.
always greater than the combined output of its part, and that is what we know as law of synergy. So you get 20 points for that. Team 2 gets 20 points. Next, moving on to team 3. Which of the following is false regarding critical path method projects? Yes, team 3. Krishan and Anmol. We can't hear you. We can't hear you. Team 3. Please, we can't hear you. Please, we can't hear you.
Hello.
Yeah. Please. What is the answer?
Can you hear us?
Yeah.
Yeah, option B.
Please read it out.
These activities must have definite commencement date but not completion dates.
Absolutely right. So that is the wrong statement about this sentence. It should also have, along with the commencement date, the completion dates. So you get 20 points for that. So at the end of round 4,
Team 1, you're with 60 points. Team 2, 50 points. Team 3, 60 points. Team 4, 70 points. And Team 5, 40 points. So Team 4 being the lead.
So now we are at the end of our rounds, round 5. This will be your deciding factor, deciding scores. And there are 2 teams which are at the same points. So please buck up and say the right answer. Okay. Round 5, we'll begin with team 5. Okay. Again, you can pass it on. The second team gets 10 points if answered correctly. So team 5, if there are 7 consecutive data points, either above the mean or below the mean, but still within the control limits, what should you do? Team 5.
Option C. We'll go with option C. Ignore it and continue to measure the process.
Sorry, that's the wrong answer. Anyone? We'll pass it on to team 1. If team 1 answers, they get 10 points.
Ma'am, find the cause because this means that the process may be out of control. It's not, it is in the control limit, but according to Six Sigma, it should not go further 3. So we'll go with D.
Right. So she gets 10 points. Team 1 gets 10 points for this. And team 5, 0. Next, moving on to team 1, your own question. You are starting a new hospital in an earthquake-prone location. You get hospital building foundations designed to absorb the earthquake shocks. What risk strategy are you adopting?
Risk strategy for earthquake prone location.
Adopting mitigation of travel. This acceptance.
I
Then I want to take risk now.
That is earthquake prone. We can't accept it.
Last 15 seconds remaining.
We'll go with I don't.
Ma'am, risk mitigation.
That's right. So you get 20 points for that.
Technology in the
Next, moving on to team 2. Cost of getting hospital certified to ISO 9001 certification is considered which of the following quality costs?
It will be appraisal cost, ma'am. Excuse me, ma'am.
I can hear you. So you want to go with appraisal cost?
Yes, yes.
It's wrong. We'll pass it on to next team. Team 3. Team 3. Team 3, do you want to take a chance? Please tell the right answer. Quick. Team 3, we can't hear you.
And prevention cost.
Yeah, that's right. So they get 10 points. Please check your audio, team 3. Because next question is for you, team 3. In the two approaches of the design for Six Sigma, DMA-DV and DMA-DOV, the difference is the O in the DMA-DOV. What does this O in the DMA-DOV stand for?
Optimize.
Excellent. You get 20 points for that.
Okay.
Next, the question is for team 4. This is the last question of this quiz competition. Emergency code pink is activated when?
Ma'am, option B. An infant or child is confirmed missing.
Very good. You hardly took any time to answer that.
Ma'am, actually, I had my placement yesterday itself, so I prepared everything for my placement purposes.
Very good. Big round for applause.
Thank you so much.
Fine. So with this, we end our quiz rounds, all the rounds, and the final scores by Raj Lakshmi.
Team 1, 90 points. Team 2, 50 points. Team 3, 90 points again. Team 4, again 90 points. And Team 5, 40.
So
there are 3 groups, three teams who are with 90 points.
Really? Wow. So which are those teams?
Team 1, Team 3, and Team 4.
Oh, okay. So what are we going to do? Tiebreaker? Tiebreaker? You all want tiebreaker?
Ma'am, give a word to all the
I
three.
think yes. I think all 3 teams should be awarded because I think 5 teams were selected out of so many people. I think everybody should be given, I think, a chance like this.
So all 3 are winners. We'll put it like this.
Yes, I have no issues with that.
First, second, third, all 3 are winners. I mean, we don't have those first, second, and third category. We'll put as winners of quiz competition SASH-2021. And we'll share the cash prize money because you'll be getting cash prize. So we'll be sharing the total amount.
How much, ma'am?
Now, because you people have decided that you are going to share, so I'll share the prize money among all the 3 teams. Fine?
Yes, ma'am.
Yes.
Okay, ma'am.
All
Yes.
the
How much
3
is it
teams will
anyways?
You'll
Yeah.
get to know tomorrow. Tomorrow we'll declare
back.
all these awards and the results. So tomorrow in the valedictory function, all 3 of you will get to know what is the prize money. Till then, enjoy.
Okay.
Well played.
Thank you
Please.
so much.
And
you.
also thanks to all the remaining 2 participants and the team, and also the other quiz participants who participated in round 1 and the teachers who motivated them. Thanks, a big thanks to all of you.
Congratulations to the winners.
Do you want to introduce yourself?
Yes.
Yeah, please. So the team 1, please introduce yourself.
Ma'am, I'm Sania Sharif. I'm doing my MBA in Hospital Administration from JSS Academy of Higher Education and Research from Mysore, ma'am.
I am Preksha Dadich. I've done my bachelor's BOT from New Delhi. Now I'm doing my master's in hospital administration from JSS AHER, Mysore.
Team 2.
I am Dr. Sanjay Yadav. I am doing MD Hospital Administration from FMC Pune, ma'am.
Great. Team 3.
I'm Dr. Anmol Jain, doing my MD in Hospital Administration from KGMC Lucknow.
Ma'am, I'm Dr. Chris Agarwal, doing MD Hospital Administration from KGMC Lucknow.
Team 4. She just left, I think. She was.
No. I'm here.
Where are you? I can't see you.
My video is on.
Yeah. We can see you.
Yeah, I'm Dr. Moindrilla Haldar. I'm a dental surgeon and currently I'm pursuing Masters of Business Administration in Hospital and Healthcare Management from Symbiosis Institute of Health Sciences, Pune.
And Team 5.
Hello, I'm Seema Jocelyn D'Souza. I'm currently doing my Masters in Hospital Administration from
Sorry, Seema, we lost you. He was Seema and he was Vipul Ingal from JSS. From Father Muller College. So all the best to all of you for your career. So with this, we'll end the session, today's session. See you tomorrow at 9 o'clock sharp. Till then, bye.